I'm so happy being here with all of you. Dear speakers, distinguished colleagues, thank you for being here at the second edition of International Congress of Preventive Medicine. Thank you again. We all are ambassadors of prevention and of the most important, I could say, part of modern medicine. Your presence matters, and I hope that will be more and more near us, because it's only the beginning. You'll take forth knowledge that will shape your practice and, for sure, the future of healthcare. Finally, I want to express my sincere appreciation to all partners and sponsors who supported this Congress, side by side Romanian Society of Preventive Medicine. Your contribution has made this event possible and helped Romanian Society of Preventive Medicine to build a stronger and beautiful prevention community. Thank you again for your participation. We move forward with the scientific program of the Congress. It's my great pleasure to announce the first session of this Congress, that is Global Preventive Medicine Strategies and Visions. This session sets the tone for our Congress by bringing together leaders, experts, who will explore the global landscape and of preventive medicine, from international policies and cancer prevention strategies to real-world public health challenges and solutions. The panel reflects a shared vision, advancing prevention through collaboration, innovation, and evidence-based action across countries and healthcare systems. It's my pleasure to invite Silvia Getcher, Health Operations Manager, WHO Country Office in Romania. Thank you, Silvia, for being here with us from the beginning of our society. Thank you again.
Good morning, and thank you so much. Once again, good morning, and thank you so much for the really kind invitation. Although I don't currently have a contract with WHO Romania, I'm hoping to return in April. Dear health professionals, esteemed colleagues and friends, it is a real honor to join you today in Bucharest for the start of the International Congress of Preventative Medicine. Once again, many thanks to the organizers for bringing together so many people united by a shared purpose: keeping people healthy, preventing avoidable suffering, and ensuring health systems can deliver for everyone, today and in the years ahead. Let me start with a simple message. Prevention starts with you. It starts with the clinical decisions you make every day, the questions you ask, the trust you build, and every conversation you have with patients, families, and communities. Prevention is not an optional add-on to curative care. It's the foundation of effective, equitable, and sustainable health services, and one of the clearest expressions of quality in healthcare. Across the WHO European region, we face a difficult combination of pressures at the moment: a growing burden of non-communicable diseases, persistent infectious disease threats, an aging population, increasing mental health needs, workforce shortages, and widening inequities. In this context, prevention is not only a health strategy, it is a resilience strategy. It reduces avoidable demand on services that are already stretched, protects health budgets, and most importantly, protects the everyday lives of people, their ability to work, learn, care for family members, and live with dignity. Prevention is sometimes described as lowering risk, but that can sound abstract. Excuse me. In reality, it is about protecting quality of life, delaying complications, avoiding disability, and preventing illness from becoming a lifelong burden. When prevention is done well, people stay healthier for longer, and health systems gain capacity to deliver timely, high-quality care to those who need it most. At WHO, we emphasize that prevention must be equitable. The burden of preventable disease is not shared equally. People living in poverty, in rural communities, marginalized groups, and those facing stigma often have high exposure to risk factors and lower access to early detection and care. If prevention is available mainly to those who are already well served, it can widen gaps. But if it is designed to reach those facing the greatest barriers, it becomes a powerful tool for fairness and solidarity. In daily practice, prevention begins with primary prevention, supporting the conditions for good health before disease begins. This includes strengthening health literacy and making it easier for people to make healthy decisions. It includes supporting good nutrition and regular physical activity, addressing tobacco use and harmful alcohol consumption, promoting mental well-being, and ensuring good oral health, which is too often overlooked despite its strong links to overall health. Your role as health professionals is central. You translate public health guidance into individual care. You make prevention practical, one person at a time. A brief intervention on smoking cessation, a short conversation about alcohol use, or guidance on diet and activity may feel small in a busy clinic. But when delivered consistently and with empathy, those actions shape outcomes across years and across generations. At the same time, healthy choices are not made in a vacuum. They are shaped by prices, marketing, housing, employment, education, and the environments people live in. That is why WHO calls for stronger health in all policies approaches. So prevention is not only an individual responsibility, but a shared responsibility across sectors. Still, in that larger system, the health workforce remains one of the most trusted voices, and trust is one of the most powerful tools in prevention. This brings me to a core priority for WHO and for preventative medicine, immunization across the life course. Vaccines are among the most effective public health measures ever developed. They save lives, prevent disability, and protect communities. They are also essential in health security, but they only work at population level when coverage is high, access is equitable, and trust is actively maintained. We should be proud of what vaccines have achieved, reducing child mortality, controlling diseases that once caused major outbreaks, protecting pregnant women and newborns, reducing severe outcomes in older adults, and enabling health systems to focus resources elsewhere. Yet, we cannot take these achievements for granted. We are seeing the consequences of disruptions in routine immunization at the moment, the spread of misinformation and increasing vaccine hesitancy in some settings. Where vaccination rates fall, outbreaks return, often affecting vulnerable populations first. The WHO message is clear: protect and strengthen routine immunization and deliver vaccination as a life course service. Vaccination is not only for childhood. It includes adolescents, adults, pregnant women, people with chronic diseases, health workers, and older persons. It includes seasonal vaccinations such as influenza, which remains a major cause of severe illness and death, especially in high-risk groups. It also includes closing immunity gaps so diseases cannot surge when coverage drops. Health workers are crucial for two reasons. First, you are the implementers. You ensure immunization is offered, recorded, followed up, and delivered safely and respectfully. Second, you are trusted advisors. The recommendation of a health professional remains one of the strongest predictors of whether a person chooses vaccination or not. In a world of conflicting information, your calm, evidence-based guidance matters. What you say and how you say it, with respect, without judgment, and with attention to the person's concerns. We should also acknowledge something openly. Questions about vaccines are not always rejection. Often they reflect uncertainty shaped by fear, past experiences, social media, or simply not knowing whom to trust. Our task is not to win arguments. It is to build understanding and confidence. Listening is often the first and also the most important intervention. Clear explanations, simple comparisons of risks and benefits, and a strong but respectful recommendation can make all the difference. Trust is built not only in the consultation room, but through the whole patient experience. Prevention and vaccination also depend on how we design services, making them accessible, culturally sensitive, and convenient, especially for those facing barriers of cost, time, distance, disability, or legal status. Prevention also includes early detection and secondary prevention. Here again, your daily work saves lives in ways that may never make headlines, but matter profoundly. Evidence-based screening, timely diagnosis, and effective management of risk factors are among the most powerful impact measures in modern medicine. Hypertension, diabetes, high cholesterol, obesity, and tobacco use remain major drivers of cardiovascular disease, cancer, chronic respiratory disease, kidney disease, and many other conditions. They are common and often silent until they cause serious harm. This is why routine actions are so powerful. Measuring blood pressure correctly and regularly, supporting adherence to treatment, checking glucose and lipid profiles when appropriate, identifying early signs of complications, and offering brief counseling interventions that help people making feasible changes. A blood pressure check can prevent a stroke. A conversation about adherence can prevent a heart attack. A timely referral after screening can detect cancer early when treatment is more effective and less costly. These interventions may appear routine, but they are the quiet strength of prevention. Practical, repeatable actions that protect people from severe, life-altering consequences. At the same time, WHO stresses the importance of doing prevention wisely, using evidence-based screening and avoiding overdiagnosis and unnecessary interventions. Good prevention respects people's time and resources and protects them from harm. It also depends on strong primary care, integrated care pathways, and reliable follow-up. Because screening without follow-up is not prevention, and diagnosis without access to care is not early treatment. This leads to another essential WHO message. Prevention is patient-centered care. Preventative medicine is most effective when it starts with the realities of the person in front of you. What matters to them? What are their constraints? Are they facing stigma, depression, or anxiety? Do they understand the advice they are being given? We know that information alone is rarely enough. Prevention succeeds when it is practical, realistic, and adapted. Small changes, reinforced consistently, can shift a person's health trajectory for years. That might mean helping somebody reduce salt intake step by step, supporting a patient to set a quit date for smoking, discussing sleep and stress as part of cardiovascular prevention, or connecting a person to community resources. The goal is progress, not perfection. Prevention also benefits from teamwork. Physicians, nurses, pharmacists, midwives, public health specialists, community health workers, psychologists, and all others contribute. Integrated teams reduce missed opportunities, especially for vaccination, screening, and lifestyle support, and help ensure continuity of care. Finally, prevention is also about protecting the health workforce. A workforce that is overwhelmed cannot sustain prevention. Safe staffing, time for counseling, strong information systems, and supportive leadership are not luxuries. They are prerequisites for preventative care. If we want prevention delivered at scale and with quality, we must design services that make it possible. Colleagues and friends, for health professionals, prevention is not an abstract policy goal. It is clinical excellence, professional responsibility, and one of the smartest investments we can make. Saving lives, reducing suffering, and strengthening trust in health services. As this Congress begins, let us embrace one shared commitment. Treat every contact as an opportunity to prevent, to protect, and to promote health. Strengthen vaccination and life course immunization. Deliver early detection and risk factor management with evidence and compassion. And keep prevention equitable so those facing the greatest barriers receive the strongest support. Prevention starts with you, but its benefits extend far beyond any single consultation. They reach families, communities, and entire health system. Mulțumesc mult, thank you, and I wish you an inspiring and productive Congress.
Thank you very much, Sylvia. I hope you'll come back soon and continue to fight with us for implementing screening programs. We have methodologies now. We have some kind of registers, but we have a lot of things to do, and we wait for you. Thank you very much. Thank you. So we'll go on, and it's my pleasure to invite on the floor a lot of very precious people. A hotspot of our Congress is Europe's Code Against Cancer, the 5th edition, one of the most important subjects of our Congress. So I invite David Ritchie, Project Officer, International Agency for Research on Cancer, WHO, Dr. Florian Alexandru Nicula, IARC Ambassador to Romania and member of IARC WHO project, Professor Maggie Krishank. Please, Maggie, come on the floor, because I want in front of everybody to thank you for being with us for the 2nd Congress. She's president of the European Federation of Colposcopy and Cervical Pathology. She co-chaired the Education and Training Committee of the International Federation of Colposcopy and Cervical Pathology. Welcome. Dr. Ostanel Ostra, Director of Self-Care. Welcome. Director of Self-Care Academic Research Unit, Department of Primary Care and Public Health, Imperial College of London. It's an honor for us. Welcome. Associate Professor Claudia Marchetti, who represents ESGO Prevention Committee, will be with us online. I also invite Juliana Dessa, Policy Officer, European Cancer Organization, because I promised you that we'll have all international organizations that are responsible for early diagnosis of cancer, and I'm very happy to have them here. Professor Invan Roche, but I need some chairs, please. I have a lot of stuff. You have to help me for... Yes? Professor Invan Roche is from Department of Public Health, Faculty of Medicine of Tirana. He came from Albania with Professor Cenk Burazeri. Welcome. Epidemiology and Public Health, Medical University of Tirana, Albania, visiting lecturer of Maastricht University, the Netherlands. I welcome all of you, and I'm sure that we'll have a wonderful panel.
Thank you very much for the introduction. I'll just make sure the slides are ready. Okay. So thank you very much for the opportunity to present here today. My name is David Ritchie. I'm Project Officer from the Environment, Early Detection and Infections Branch, EPR, at IARC. IARC is a specialized cancer agency of the World Health Organization. And I'm here to present today on behalf of Dr. Joachim Schulz, who is the lead of the initiative to develop the 5th edition of the European Code Against Cancer. So today I will give you a walkthrough of the European Code Against Cancer 5th edition, which is quite fresh. It was published only just a few months ago. And then the next speaker after me is Florian Nicolau, who will give you a really interesting and complementary presentation on the new innovations within ECAC 5 in regards to recommendations for policymakers. But here today I will do the overview of the European Code Against Cancer initiative, focusing on the recommendations for the general public. In terms of this initiative, the European Code Against Cancer, this is something from the European Commission. It's an EU initiative stretching back now almost 40 years. So the first edition was published in 1987 with 10 recommendations. Thereafter there was an update, a second edition, in 1993, which revised slightly those 10 recommendations, adding in additional information, suggestions for the public in regards to secondary prevention, so for cancer screening. Thereafter, a third edition was published in 2003, expanding and refreshing more the recommendations that now covered 11 topics, bringing in, for the first time, vaccination. And then from 2014, IARC took the role in the coordination of this project, of the initiative to develop the European Code Against Cancer recommendations, publishing the 4th edition in 2014. This 4th edition is interesting because it was the first in which the phrasing of the recommendations for the general public was really interrogated to make sure that they were as understandable and actionable as possible. So for the 2014 4th edition, 12 recommendations were issued which give general public guidance they can take for themselves and for their family to reduce their cancer risk. In 2025, we published the 5th edition, which I'll elaborate further in this presentation. But here you can see basically with this slide the chronology and the development, the overview of the initiative for the European Code Against Cancer, which shows how progressively, every decade or so, the evidence is reviewed, recommendations are revised and updated according to the latest science evidence that is available. So we had in the 4th edition 12 recommendations about actions the general public can take to reduce their cancer risk. And now with the 2025 5th edition, we started to look at what we can do based upon the latest available evidence to refresh and update and revise these recommendations. To do this, it was a 4-year project funded by the European Commission, which brought together across 5 specialist working groups looking at different thematic areas from lifestyle to preventative interventions to the environment. Each of these working groups were comprised of 12 experts, so we had 60 experts in total from across the European Union and associated countries. And they were the ones who were responsible to bring their knowledge and expertise to revise the evidence in order to propose recommendations that can be included within the European Code Against Cancer, which will be as relevant, as timely, and as actionable as possible for the general public to be able to understand and follow without any specialist knowledge, skills, experience in order to reduce their cancer risk. So the experts in these working groups proposed the recommendations, which were then scrutinized, reviewed, accepted, or modified to some degree by a scientific committee of 13 experts, which includes Florian, was in there. In terms of the scope and the general distribution of the experts involved within this process, we had an excellent, I think, geographic distribution, as you can see on the slide, and we also had a very nice gender balance there. I mentioned that we have the scientific committee who are responsible for reviewing and adopting the recommendations the experts had proposed, and this was composed of 13 members, and you can see here on the chart the map in terms of the countries that were covered by these experts, most of whom were working for a national cancer center or institute in their respective country. There were 12 EU member states covered, which includes Romania, with Florian's kind participation, plus representatives from headquarters of the WHO. So these were the people who were responsible to look at the proposed recommendations the experts had reviewed over a period of around 12 months or so. And then in a couple of plenary meetings together, they would make the decision whether to include or not these proposed recommendations. If they had questions and modifications to make, these were sent back to the respective experts to revise, review, and propose again. In terms of the general criteria and methodological approach, in terms of how the experts reviewed the evidence and what processes they followed to be able to ultimately come up with a recommendation to propose to the scientific committee, there were 4 steps that they had to follow. Firstly, the starting point for the experts in the working groups who were proposing these recommendations was to begin with the present, at that time, version of the European Code Against Cancer, so the 4th edition, published in 2014, and therein see which of those recommendations needed to be modified, updated, revised in line with the latest scientific evidence. As you can appreciate, that edition, the 4th edition of the European Code Against Cancer, was published in 2014 based on a review of evidence from the previous couple of years, so 2011 to 2013. So it was, by the time we started this project in 2022, already a little bit out of date, you might say, in terms of being in line with the current trends and current scientific evidence that had emerged since the publication of the 4th edition in 2014. So there was a lot for them to review in terms of new innovations, additions to the scientific knowledge in those areas that were included within the 12 recommendations of the 4th edition. The starting point was there to look at these 12 recommendations and see whether updates needed to be made, and also to consider new recommendations that perhaps could be included for first time or brought back from previous editions, again, based very much on the scientific evidence that was available. In terms of the evidence that they look upon in order to make these decisions, we relied very much on our monographs for the classification of hazards that we produce at IARC, so the IARC Monographs Handbook, which is really the definitive program that really classifies agents that have the potential to cause cancer. So for causality, this was the key documents that we were looking at in terms of the evidence base for deciding on the association between a possible topic that can be a recommendation for inclusion in the code and with cancer itself. So the evidence would be scrutinized by the experts as a first step to make sure that their weight was in favor of a positive association with cancer, or to show that the possible topic for inclusion within the code had a strong preventative effect to reduce the risk against cancer or prevent outright. And thereafter, if this was satisfied, the experts would then look in terms of the suitability, acceptability, timeliness, and relevance for the region of consideration, which is the European Union member states primarily, to see that this topic was really one of concern for the region. This was an important step to avoid including too many topics which are perhaps too niche or don't have a broad enough prevalence or relevance to the population within the EU, so that we don't have an extremely long list of recommendations in the code, but also things that are of interest to very specific groups, high-risk groups, are perhaps better dealt with more specific initiatives and interventions rather than a very broad initiative such as the European Code Against Cancer. After that step has been considered, then the experts would really look at the phrasing, at the formulation of the recommendations, seeing that this was understandable and intelligible to the general population. So this was an innovation brought into the 4th edition to really put a lot of emphasis and to ensure that the phrasing of the recommendations themselves are as clear, precise, and understandable to the broadest number of people possible. And that's something that was carried forward, carried over into the 5th edition. And then lastly, once these steps had been looked at, the experts also considered and did a broad review in terms of associated policies that are available to also be included alongside the recommendations for the public within the 5th edition of the European Code Against Cancer. So this was a big step forward, I think, for the 5th edition of the code by including not only recommendations that are actionable, understandable for the general public to follow, but also to include directly recommendations for policymakers, for decision makers, on what they can do on that specific topic. So we would have a recommendation for the public about tobacco smoking, urging them, of course, as you can appreciate, not to smoke. And then complementary to that, a specific recommendation for decision makers, policymakers, on what they can do also to reduce the cancer burden associated with that risk factors, which is primarily to implement fully FCTC and EU directives and regulations. Again, Florian will talk more about the specific recommendations for policymakers in his presentation, but it's really the big improvement and step forward for the 5th edition of the code. So once all these steps were satisfied, the recommendation was then drafted, presented to the scientific committee, who would consider it, propose changes, or adopt outright those recommendations. One interesting thing that was also included within this project was a short study done by Eleni Mansari at the University of Cambridge to get an assessment or understanding of what citizens and the general public knew about cancer prevention and the agents or the risk factors that are associated with cancer itself. So there was an online study that was done across 8 countries and 10,000 participants, whereby they were asked a series of questions in terms of the previous edition of the European Code Against Cancer and then a draft edition of the 5th version. And the objective of the study was to see, without prompting, how many of these risk factors that we know from the evidence are associated with cancer, either in a positive way in terms of prevention or associated with as a causal factor with cancer. What of these risk factors could the persons participating within the study identify correctly? And what was troubling to see really from this study was that without prompting, so asking to list spontaneously, there was only, roughly speaking, 2 of the risk factors that were available within the list that the individuals within the study were able to identify. So without prompting means there was no multiple choice list present to them, but simply asked an open field to name things that you think are associated with the cause cancer. On the whole, across the 10,000 participants in the 8 countries, only 2, as an average, only 2 risk factors were typically identified by these participants. So this shows really the need for the type of initiative as the European Code Against Cancer as a basis through which to communicate to the public evidence-based, understandable, actionable recommendations that can hopefully increase this low cancer literacy that we see in the participants, and which is extended across the European populations. So turning now to what is included within the 5th edition of the European Code Against Cancer, here you can see the overview, the infographic really, of the 14 recommendations that were included in this new edition, which was published first in October 2025 in English only, and then in World Cancer Day of this year, on 4th of February, in all EU languages. So firstly it was in English, and then the translations followed just last month. So they are now available online. And in terms of these 4 recommendations, I will go through very briefly. As you can imagine, we continue to include tobacco smoking, secondhand smoke exposure to other people's smoke in different settings at the home, in the workplace, but also in vehicles, overweightness and obesity, physical activity, diet and nutrition. So factors that are included there are preventative in terms of things you can consume, nutritional products that reduce cancer risk, but also those which are shown to be associated with increased cancer risk. Alcohol, which we think is very important because in the studies in terms of public understanding of the risk factors for cancer, this often rates rather low in many countries. Breastfeeding as a protective factor for mothers. Artificial and natural solar UV radiation, so solar radiation from the sun, and also artificial radiation exposure from sunbeds. Occupational carcinogens. Indoor radon gas exposure, which was introduced for the first time in the 4th edition and has an important contribution to lung cancer burden. Both indoor and outdoor air pollution. Cancer-causing infections, so primarily we keep here the recommendations on vaccination, but also introduce for the first time some preventative strategies for test and treat in certain infections. Hormone replacement therapy, and lastly, organized cancer screening programs. So these are the 14 recommendations that are included within the new edition of the European Code Against Cancer, ECAC 5, that's now available in Romanian and all EU languages. So here, just as we come to the end of the presentation, you can see on the far side of the screen the previous edition of the code, ECAC 4, with its 12 recommendations. And then on the other side, we have the new edition, the 5th edition of the European Code Against Cancer. And just to highlight a few of the things that have been included that are new modifications, adaptations in the 5th edition versus the 4th edition. We include for the first time reference to e-cigarettes, electronic nicotine products. So this is a new element that has been included within ECAC 5 and is referenced here as vaping products. Also brought back from previous editions of the code is a reference to cessation. The recommendation on secondhand smoke also includes reference to exposure within a private vehicle. The recommendations on overweight and diet were strengthened in terms of the recommendation on overweight, now including those elements which contribute towards high body fatness, where previously this was included within the diet recommendation. The physical activity recommendations stayed largely the same. In terms of the recommendation on alcohol, this was strengthened to be much more directive and includes now the word to avoid alcohol products, whereas in the 4th edition, this was a more lighter version, was to say to the individuals in the general population, reduce or limit your consumption of alcohol and not consuming alcohol would be best for cancer prevention. This has now been made much more stronger and forceful based upon the available evidence. What's also very interesting to see in terms of new recommendations outright is for the air pollution. So this is both indoor and outdoor air pollution, exposure to the pollutants both outside and in daily life, but also elements that are possible in the indoor setting. These are now included as a fresh recommendation for the first time within the European Code. And then also really important, I think, and interesting for this audience, the recommendation on infection-associated cancers has been strengthened in terms of the vaccination component when it comes to human papillomavirus vaccination. In the 4th edition, published in 2014, this was a recommendation simply towards vaccinating girls against HPV, because that satisfied the evidence at that time, which was now more than 13, 14 years old. So as an illustration of how the evidence has evolved and the code has evolved alongside it, we now have a gender-neutral vaccination schedule recommended within the 5th edition. Also included is test and treat strategies for certain additional infections and viruses associated with cancer. And then lastly, I think also important for this audience that the recommendation on cancer screening was enhanced to include a positive message for participating within organized lung cancer screening, should it be available in your country. Just for the final few slides, to give you a snapshot of some of the evidence that was reviewed or commissioned to support the experts to make their decision. With regard to the inclusion of e-cigarettes, which is now a new topic within the first recommendation on tobacco products, the experts commissioned a systematic review and meta-analysis in regards to the gateway effect of consuming e-cigarette products leading towards the consumption of traditional conventional cigarette products. And as you can see from the forest plot here, when we're looking mostly also of interest towards younger populations, so adolescents and young adults, you see that there is an effect in terms of those who have ever used e-cigarettes versus never used cigarettes, who then go on to consume or to report they consume conventional cigarette products. In terms of the recommendation on infection-associated cancers, the experts within this group did some additional research and analysis to look at the population attributable fraction of these key oncogenic virus and the bacteria of Helicobacter pylori to see to what extent this contributes to the cancer burden in Europe. And they estimated, I think on 2022 figures, around 5% of cancers are associated with these 4 infections. So H. pylori, HPV, hepatitis C, and hepatitis B. On this chart, on the screen, you can see the chart with the map of the geographic distribution of the impact of these viruses and bacteria within Europe. And then lastly, with lung cancer screening, there were a couple of reviews that were commissioned to support and endorse the growing evidence in favor of low-dose CT for lung cancer screening. And the first review, which is outlined in the paper that is linked to on the screen, this clarified and I think fully in agreement with the big trials that were published in between the period of the 4th edition of the European Code Against Cancer in 2014 and the most recent version in 2025, so the Nelson study published around 2020, and it showed that the strong all-cause mortality effect for participation in lung cancer screening. The experts, of course, were very conscious and aware of the harms and the potential adverse effects of participation within such screening programs, so commissioned additional review to look at the possible overdiagnosis with participation in lung cancer screening. And as you can see from the evidence to decision table that's presented on the chart here, both from a clinical and public health perspective, the overdiagnosis was estimated to be at a very acceptable rate. So taking this together with the mortality benefit and the growing number of countries that are gradually piloting and introducing lung cancer screening, this was introduced into the European Code Against Cancer. All of the scientific articles that was outlining the justification, the evidence, the rationale, the decision-making processes that were followed to come up with these 14 recommendations, both for individuals and for policymakers, are outlined in a special issue of the Journal of Molecular Oncology, which was published earlier this year. So you can read those articles and see exactly the steps that were taken, the evidence that was reviewed, and the judgments made for each of those recommendations, the topics that they cover in this particular special issue of the journal. So I encourage everyone to follow the link and read those articles, because they really give a lot more detail and outline, I think, very nicely the steps that were taken and the evidence that was considered for arriving at those 14 recommendations. So once again, thank you very much for this opportunity. I'm very honored to be invited to speak at the conference, and it's a real pleasure. Thank you, and mulțumesc.
Bună ziua! Aștept să apară prezentarea. Până apare prezentarea, vreau în primul rând să mulțumesc. În primul rând, I first want to thank WHO for patronizing this project, this whole project, the revision 5 of the European Code Against Cancer. implemented by the International Agency of Cancer Research, represented here by the project officer, David Ritchie. Thank you, David, for your presence and for everything you have done in helping us all over the time organizing our work in cancer prevention. At last but not least, I have to thank to the President Roxana Bohâlță of the Romanian Society of Preventive Medicine to offer us the privilege and the opportunity to disseminate the code to at least the health providers which are involved in prevention and which are members of the society or attending the work of this Congress. And I don't know the presentation. Okay. It's too little. I can't see it. Thank you. So this is the solution to stay like this, if it's okay with the audience. This is a publication of the scientific committee of the project, describing the project. Nobody can describe or present the project and the recommendations better than the officer of the project, David Ritchie. He had a comprehensive presentation of the code. He left me only some few remarks to make about the recommendation for policy makers, which are included in the code. I will skip the presentation related to ICAC, as they were already mentioned. It is important for us to mention that, for the policy makers, that 40% of the cancers are considered to be preventable. And this is important when we look to the fact that since 2024, Romania is leading. It's in the top of mortality with preventable, non-communicated diseases. I hope you forgive my English. It's very difficult to speak in English after David Ritchie, you know. It's okay. And this should be a motive for everybody to be involved in disseminating the code, as the code is a real important tool for prevention in our country. The policymakers are invited to choose some strategies which are the easiest and affordable and accessible and can be an option for all the settings involved in cancer prevention. And it is important for me to mention that Romania needs a tremendous effort in investing in the capacity building and monitoring and evaluation of further interventions and measures of cancer control in the domain of prevention. Of course, the code is recommended to be promoted as a whole, without any changes in the text. It is very important because the specialists involved in the elaboration of the code invested a lot of time and efforts in taking care about each word involved in transmitting the message, the recommendations of the code. That is in the English language, of course, but it's almost important for all the language in which the code was translated. So the translation was supervised of these recommendations. Policymakers are urged to support and engage in efforts to communicate the recommendation of the code. After this launch of the code here in this Congress, I will do some effort to disseminate the code at all the levels in Romania of decision makers. That means the Parliament Commission on Health, that means the Ministry of Health, that means participation at meetings like this with professionals that are involved in disseminating the code, and at last but not least, dissemination to the population, including the recommendation of the code in some curricula of health education in schools. That can be an example of dissemination, and that it's valuable and important for all the countries involved, because the knowledge and the awareness about these measures of prevention are very little in the population of risk. I mean, I know it in Romania, I do not know. I think that all countries have this important issue to solve. The recommendations, 14 recommendations, were extensively presented by David before me. I will speak only about the recommendation to policymakers, which appeared now in these fifth revisions for the very first time. I was involved in the fourth revision and fifth revision. Fourth revision contained only recommendations for the public about the measures to and interventions to be recommended to prevent cancer. All these recommendations that should be presented as a whole, as I already mentioned, can be grouped in some categories. This is important for addressing messages to different categories of targets: population, health professionals, and policymakers. A lot of measures like those 1 to 6 are addressing not only cancer, prevention of cancer, are addressing some other non-communicable diseases that can be prevented by diet, for example, by physical activity, tobacco. Also, tobacco is very important to be mentioned here. The environmental factors are another category. In the medical interventions are a last category I will refer on when we speak about messages for policymakers. And from all these recommendations for policymakers, I will focus only on those related to medical interventions, because we are here at meeting people who works, mostly people involved in cancer prevention, and the message should go from them. And from all these 14 recommendations, I will focus on vaccination and on screening, because those are my domain of expertise. About vaccination, which addresses the cancer-causing infections and our interventions related to that, I will speak a little bit about HPV vaccination, which is very important to Romania to organize campaign of vaccinations, proper campaign of vaccinations, effective, efficient, with good coverage campaigns of vaccination, because we face some incidents, the highest incidence and mortality in cervical cancer in Europe. So this can be considered the most urgent public health intervention needed in cancer control in Romania for the moment. The recommended ages to start these vaccinations is 9 to 14 years. Of course, it is a lot to talk about, some studies to be made here about the age in which the youngs in Romania are starting their sexual activities, and to personalize for our country, for example, those recommendations. The coverage that is recommended, 90%, which is one of the targets at the European level. It is, I think, a dream for Romania as the things looks now, as the campaign results are reported now. Anyway, in the Romanian health strategy 2023-2030, the percentage is lower, up to 50%, as I remember, published by the Ministry of Health, but it is still, I think, optimistic for a 5 years period. The catch-up vaccination is recommended until the age of 18 years old. The Ministry of Health declared that up to 26 years, as is scientifically sustained, it is allowed to be, it's compensated, but the vaccine 50%, I think, no, I don't know if anybody can inform me better, but 50% of the vaccine is compensated up to 26 years old in Romania now, and receiving doses after this age should be justified by HIV, for example, infections, or in some particular clinical cases up to the age of 45, according to literature. It is mentioned here that identifying behavioral determinants of vaccine uptake, addressing obstacles to vaccinations are important. And here I have to mention that they tried, in Romania, the decision makers tried to organize school-based campaigns which failed. And now the campaign is based on family doctors, which are in the front line, and the people must ask the free vaccines there at the level of family doctors with informed consent of the parents. It's a little difficult to expand strategy, and it's still not working very well in terms of coverage of population, of kids population. The progress of vaccination, the register of vaccinations linked with registries of screening are again a dream for the moment in Romania. But there are very important tools to have a population control based of the efficiency of these kinds of interventions in cancer control, in cervical cancer control mainly. About cervical cancer, about cancer screenings in general, I can tell you that you see the colorectal cancer screening is recommended between 50 and 70 years old based on of analysis and not on endoscopy, as it should be recommended. I can underline here that we have a big barrier in terms of resources of endoscopy. And maybe we should focus on endoscopy in the first line to develop the capacity of the endoscopy to make to evaluate the number of cases that will rise after a population-based analyzed fecal blood analysis. This is a very important limit to be considered. Then this is a message for the decision makers, specific for Romania. In breast cancer screening, mammography is recommended between 50 and 69 years old. Some local regional and regional projects were developed, and now we have a program based to help the population which are defavorized on EU funds is the project, and this is the same in cervical cancer screening too, regarding the so-called organized screening, cervical cancer screening, which is now included in the strategy of screening in Romania. The recommendation is to use HPV screening, primary screening between ages of 30 and 65 years. Here we are facing an anachronic extensive use of Babeș-Papac-Nicolau tests, which belong to an historical era of cervical cancer prevention, if you want, together with a strategy of waiting decades to obtain control in mortality and incidence. Romania is from decades in the top of cervical cancer and incidence, and I don't think we have time to wait another decades on the first place in mortality with this kind of strategies. We need some other faster HPV faster strategies, or even faster strategies, combined with a lot of new modern resources to obtain some results as soon as possible in order to cut this situation in which we stay on the line of highest mortality and incidence in cervical cancer screening. We are starting now organizing, implementing, and somehow monitoring lung cancer screening programs, and even prostate cancer, which are not mentioned here in the recommendations, but Romania has on the label implementation of prostate screening cancers. This is a situation now. I will talk about it extensively in the second presentation, which is focused on gynecologists mainly and other specialties, cytologists, pathologists, communication experts, IT experts, AI experts involved in the panel of multi-specialist kind of approaching the problems of quality assurance and control in an efficient screening program. I came to this Congress to declare that we are going to sustain any efforts of the Society of Preventive Medicine to plan, organize, I don't know, maybe implement and monitor interventions on cancer control. We offer our expertise. EARC will work in the future in elaborating understood new guidelines of quality assurance and control in screening programs together with GRC. And you have now the connections, the professional society, to be aware about these recommendations all over your efforts. And finally, I want to mention that we have to empower the role of the professional societies. This is one of the reasons I'm here, in counseling the policymakers. The professional society must find a way in Romania to be more efficient, more present, and more represented in taking decisions about organizing health problems in our country. Thank you very much.
Good morning. I'm Maggie Cruikshank. I'm president of the European Federation of Colposcopy, and I'm really honoured and delighted to be here because we share the same ambitions in preventing cervical cancer and ensuring that across Europe, women receive the same quality assured and standard of care in that prevention. Can I get my slides, please? Thank you. And of course, there are huge inequalities in cervical cancer. And whilst we expect to see high rates of cervical cancer in Central and South America and Sub-Saharan Africa, sadly, we also see these high rates in Eastern Europe. And it's not about differences in the biology of the disease, it's about the commitment and investment and implementation of prevention of cervical disease. And that's why WHO has set out this strategy to prevent cervical cancer, with 90% of girls receiving HPV vaccination before the age of 15, 70% of women receiving a validated cervical screening test by age 35 and by age 45, and 90% of women who have got precancer or cancer of the cervix having access to treatment and management, including palliative care. So we see This is at the top 10 of rates of cervical cancer, mostly in sub-Saharan African countries, but also in Montenegro and in Romania. Not because of the differences in the biology of the disease. When we take into account the differences in demographics in these countries, yes, with age standardized rates, it's not so dramatic in Romania, but that there remains these huge differences. So is there a miracle cure? Well, of course, the miracle is not the cure, it's the prevention of the disease. I find it the biggest change in my clinical practice as 40 years as a gynecologist has been the HPV vaccine. I find it incredible. When I was a medical student in the 1980s, we did not know that HPV was the cause of cervical cancer. And now I have 2 adult daughters who've been vaccinated against this disease. And in my clinic every day, I am seeing the huge impact we've seen from HPV vaccination. So WHO put out this first call in 2020, so the first global call for the elimination of cancer. And the target was that cervical cancer will become a rare disease globally. And we need to accelerate that process if we're going to achieve this. And they're monitoring 194 different countries. And just to be clear, we're not talking about eradicating cervical cancer, but eliminating it as a public health issue so there are less than 4 cases of cervical cancer per 100 women per year. And the acceleration that we've just been hearing about is essential because we're not going to see that huge impact without accelerating that process. There will be huge numbers of deaths and cases of disease that can be prevented through this elimination policy. But you can see that this is quite a long-term strategy, and we're looking forward almost 100 years to see that huge global impact. And when we see the number of deaths that we can prevent, it is a compelling argument to accelerate the process. And if we look at the current status of disease, even in the United Kingdom, Scotland, where I work, and in England, we're not achieving that target set by WHO, although we have an HPV immunisation programme and we have cervical screening. So in the UK model for the prevention of disease, we have population-based screening. And we have seen that if it's not population-based, it's not effective clinically, and it's not cost-effective. We have HPV primary screening, which got introduced in the constituent countries of the UK at different times, but since 2020 in Northern Ireland just implemented HPV screening last year. It is presented that HPV vaccination and screening are one strategy, a combined strategy to prevent cervical cancer. It's not about sexually transmitted infections, it's about cancer prevention. And there is quality assurance of every component of the HPV immunisation programme and of the screening programme, and each component part of the programme is accountable and is monitored on their function. So the key components of the HPV vaccination is to vaccinate early and to vaccinate before the age of 15. The UK, we moved to gender-neutral vaccination in 2019 for equity amongst genders, but also to provide robustness to herd immunity in the prevention of cervical cancer. And there has to be integration of the health services in incorporating HPV vaccination into routines. And for most parts of the United Kingdom, that is done through a school-based programme. In 2 regions in England, where it is done in primary care through GP practices, there has been much lower uptake, and best uptake has been through the school programme. Engagement has been a very important part, both in education and sensitisation about screening and immunisation, but also in responding to any claims about adverse effects of vaccination in the mainstream press and having very considered, thoughtful and compelling responses to that. So combating misinformation has been an essential component. And yet, in the United Kingdom, where we have had high uptake of HPV immunisation. We have seen falling rates since COVID. There has been increasing vaccine hesitancy. But also, and this relates to health inequalities because of school attendance. So in areas where there's low school attendance, we have seen problems with HPV vaccination uptake, which shows it's not just a health issue or a public health issue. It's a societal issue about making sure that children have got access to routine and access to education and school attendance. So it has been challenging, the decline in vaccination rates, and certainly it's in areas of higher deprivation that we see those reduced rates. And you'll see in the graph on the right-hand side that in fact London has the lowest rates of HPV vaccination uptake. So it needs political commitment and investment to address these multifactorial issues which are impacting on vaccination uptake. Talking about how to accelerate it, this graph comes from Julia Brotherton's modelling work from her group in Australia. And the top grey line shows what would happen if there's no vaccination or cervical screening. And to obtain maximum impact in accelerating the reduction in cervical cancer deaths, it requires a combination of vaccinating and 2 lifetime screens and providing treatment for cancer. So all 3 pillars of the WHO call are necessary to do that. So what have been the opportunities in the United Kingdom? Well, adoption of high-performance tests. After decades of using cervical cytology, despite all the efforts through quality assurance, the test was never going to function any better without bringing in HPV testing. There needs to be policy and political commitment because you need a long-term strategy. It's not going to work if each new government are changing what we're trying to deliver. And essentially, that funding for this, which involves so many different component parts, including primary care, secondary care, and prevention, that there's ring-fenced funding. And there needs to be a willingness to accept that there are short-term costs for long-term gain. And that's particularly important with the HPV immunisation programme, where we're going to see reduction in cervical cancer deaths decades after girls are vaccinated at age 10 to 12. Workforce design is important because there are so many different component parts between primary care and smear taking, laboratories, colposcopy, public health. And there needs to be training linked to these standards, and there needs to be understanding between each component part. So every quarter I meet with my cervical screening monitoring group as the colposcopist, but I'm meeting with public health, with the HPV lab, the cytology lab, representatives from general practice and the pathology labs, so that each part is working together to achieve the same aims. Equity of access is a problem even in the United Kingdom. And there needs to be access to cervical screening services and access to colposcopy. So on Monday, I will be going to the Shetland Islands to do my monthly colposcopy clinic. I get on the ferry from Aberdeen. It takes me 12 hours to go up to the most northerly part of Scotland, and I spend the day there doing colposcopy. But I have to appreciate that I have patients who will have had to get on 2 or 3 ferries to get to that main town in Shetland to come and see me, and we're meeting halfway. Monitoring and evaluation is essential, and I'll show you some of the data from Scotland. But to have data and IT infrastructure is absolutely essential because we do not know if we're achieving and our efforts are having an impact unless we're monitoring that. In Scotland, everybody has a unique identifier, and therefore we're able to accurately link our data from the cancer registry to the cervical screening programme, to the immunisation records, to the colposcopy and laboratory records to do that work. So what lessons and mistakes have we made in the UK? What have we had to learn the hard way? Well, opportunistic screening increases inequality. because it is the worried well who will attend for screening and your most high-risk women won't attend. Technology without governance fails, so it's not just having the best tests that will work. And workforce sustainability matters as much as the test accuracy. And all the changes that we have made moving to HPV testing have very much depended on engagement with the workforce and forward planning to ensure that delivery, when we've gone from 13 cytology labs to 2 HPV labs. So this is what happened in the United Kingdom. Many regions brought in cervical screening in the 1950s and the 1960s. It was opportunistic screening, so when women were pregnant or attending for family planning, they had huge numbers of smears done, but otherwise they often went unscreened. So although we were doing huge numbers of smear tests, we were not having an effect on cervical cancer prevention. And it was in the late 1980s that it was noticed how much work was going into screening, and yet our cervical cancer rates weren't changing. And it was only in the late 1989, 1990 that we brought in population-based organised screening, which hugely increased the uptake of screening and had a dramatic effect on the reduction of cervical cancer. And colposcopy is an important part because screening women will not prevent cancer itself. The screen-positive women need to come colposcopy if we're going to identify disease, detect disease, and treat disease. And WHO emphasises the importance of standardising colposcopy procedures because we need to ensure good diagnostic accuracy and proper provision of effective treatment, or else screening programmes will come to have a poor reputation if we're not properly treating women and preventing cancers and ensuring that we're not providing disbenefits of over-treatment and over-interventions. So there needs to be integration between that screening and treatment pathways to make sure that women who screen positive have got access to colposcopy and appropriate treatment for their pre-cancer lesions. And there needs to be training and capacity building because a screening programme will not deliver benefits if there is not a service to then manage women who screen positive and treat them effectively. So why does this call matter to the UK if we have relatively low rates of cervical cancer? Well, we do have a robust infrastructure, but there are still inequalities there related to deprivation, related to rurality and remoteness, related to some of the ethnic groups. And of course, cervical cancer is a preventable disease. It doesn't matter if you're in a low, medium or high income country, it's a disease that can be prevented. And we know that we have the tools to prevent it through HPV immunisation and cervical screening and effective treatment of pre-cancer. And certainly as colposcopists, we have an onus to ensure that we have adequate and timely treatment and that we are working with the whole programme to deliver that. So that there are different health services in the United Kingdom. Each country in the United Kingdom has their own NHS service and their own screening programme, and there are differences between them. And probably the biggest challenge to us is the fall in cervical screening, which where I work in Scotland was 86% uptake, and we're now down to 64% uptake. So it's a genuine issue. And there's currently a lot of work being done to see how we can do that. A lot of the disparities in the United Kingdom are related to deprivation, with cervical disease highest in the most deprived women, who are also least likely to get vaccinated and least likely to attend for screening. But certainly COVID has had an impact on the uptake of vaccines. Currently there's a huge problem in the United Kingdom with meningitis and deaths from meningitis. And where I work in Aberdeen, we are now reporting cases of measles that we haven't seen in 20 years because of the reduction in uptake of immunisations. So what is the impact in Scotland on achieving those WHO targets? Well, currently our modelling work in Scotland, where we've got high uptake of vaccine, about 60% uptake of screening, is that we will reach the elimination target of WHO in the next 25 years. But the women who are least deprived will achieve that by 2032, so just in 6 years' time. But the most deprived women won't reach that until 2061. So there's a 25-year age discrepancy related to deprivation, which needs to be addressed. So certainly we need commitment from all levels, and a sustainable programme needs funding to support it that's not going to be diverted to other competing interests, and quality assurance. It's also essential that our screening programme in cervical disease is treating pre-cancer, but we need to be included in the cancer strategies for us to be taken seriously and given the same support. And we need integrated data collection, as I've described in Scotland, to monitor those systems. There are challenges for colposcopy, particularly with HPV screening, which increases the number of referrals to colposcopy, ensuring equity of access, ensuring that women are not defaulting and that they are attending for treatment and prevention. And we need to work with all parts of the system if we're going to assure timely and effective prevention of cancer. And in Scotland, we have an audit and QA system where every clinic in Scotland uses the same data collection system. So we have a national colposcopy clinical information and audit system that all colposcopy clinics use, so we're collecting real-time data. So this comes from the system that I'm talking about here, and this is monitoring our referrals to the colposcopy clinics. So the yellow line is the new referrals to colposcopy. We started our HPV immunisation programme in 2010, and from 2015 we can see a steady decline in referrals to colposcopy as a result of HPV immunisation. There were other changes to the programme. We changed the age limits for screening, we changed the frequency of screening, but that steady decline reflects HPV immunisation rather than other temporal effects. Not surprisingly, in 2020, because of COVID and we suspended screening for 6 months, there was a big dip. But at the same time as COVID, we changed to HPV screening in Scotland. And the result of that, you can see, having had a steady decline in new colposcopy referrals, we had a big increase in colposcopy, which has levelled out and continued. We've entered our second round of HPV screening last year, and we're continuing to monitor, because it's very important for delivering an effective colposcopy service that we understand who's coming from the screening programme and have we got the workforce capacity to deal with that. So training, as I said, is important. In the top left-hand corner was a colposcopy treatment course that we ran in Yash last year with Professor Mihaela Grigori, who you see there with Deirdre Lyons, the president of the British Colposcopy Society. So cervical cancer prevention is highly cost-effective, but only if it is delivered at scale. So it needs to be a population-based systematic programme. Fragmented or short-term funding increases inequality, it undermines trust, and it wastes resources already invested. So it's important to have a countrywide programme. And to be sustainable, it does need predictable multi-year funding with alignment between health insurance, between public health budgets, between EU funding. And it's investment in infrastructure and not just in tests. Interestingly, Babeș introduced the first test for prevention of cervical screening in Romania in 1928 and published on the Babeș test, which is used to this day. And yet, in Romania, we have such high rates of cervical cancer. And interestingly, most people will have heard of the PAP test after Papa Nicolau, who published his cervical screening test after Babeș. So EU alignment involves not us following the same recipe or programme, but sharing standards, data and accountability. So finally, I would like to say, if you're interested more in colposcopy, the European Federation of Colposcopy, we have our Congress in Bucharest here in October this year, and we'll be providing a number of workshops and masterclasses in the pre-Congress course if you're interested in further development of colposcopy skills. These are the references I've used, and thank you very much.
Thanks. Hello everyone, so thank you very much for inviting me here, and thank you, Madam Chair, for your invitation, for your hospitality in Romania. My name is Austin. I'll be giving 4 talks in the next 2 days, so I thought I'd start with what was recommended when my slides come up. This is my 2nd time in Romania. I was here last year in Cluj. That was a very nice trip, but my 1st time in Bucharest. And with somebody with ADHD, I'm finding it very difficult to sit on a chair and do nothing. So maybe after this, I might be taking my station on the couch. Thank you. Okay, great. I'm just waiting for the slides to come up. Thank you. Thank you. I think there may be a full screen, fantastic, if there's a full screen version. If it's possible to open in a PDF, there's the option to press a full screen, or we can continue like this. At the moment, it's opening on Google Drive. If it's possible to open it as a PDF, as a standalone PDF, it would go to full screen. Thank you.
Try to fix the problem in the
Sure.
meantime.
Okay, yeah, that's fine. Yeah. So we'll just wait another, I can start slowly. If the slides can come up in any format, I can maybe just go ahead. Thank you. I'm happy if the slides go up like before, we can, oh, fantastic, thank you. And there should be a full screen mode if that's, yeah, great, okay. Well, thank you very much. My name is Austin. I'm from Imperial College London. I'm here to present today the first of 4 talks, the evolution of self-care, and how it's important really to see how we can orient health systems in preparation for our life in the 21st century. So this is a bit of Romanian for you. So I'm director of the Self-Care Academic Research Unit at Imperial, and I'm PI of the biggest study, global study on misinformation. We've been hearing a lot about that earlier, and maybe towards the end or later, tomorrow, we'll talk more about that and what we're doing to tackle misinformation and the impact of exposure to misinformation on health and care. So I'll be delivering 4 talks in the next 2 days. The first one is looking at which is why I'm here now, the evolution of self-care and how we should reorient health systems. But I wanted to draw a narrative arc that actually ties up all 4 talks. The next talks later today will be on health span over lifespan, and tomorrow we're looking at social determinants, lifestyle medicine, and then concluding with precision medicine and the importance of polygenic risk scores in the context of prevention. So the Self-Care Academic Research Unit is a collaboration between the International Self-Care Foundation and the Self-Care Forum UK. And we established the unit in 2017 precisely because I think humanity has forgotten about self-care. Since inventing pharmaceutical medicine and surgery, there's a lot of emphasis from policymakers and even patients want a treatment. But we've been hearing this morning, and more so in the future, that it's really important to rediscover the oldest type of care and focus on prevention and see what people can do to help themselves. Because without this, we'll have this constant problem of an unsustainable situation. And we established SCARU in 2017 precisely because there's a recognition that the real epidemic is an epidemic of preventive and lifestyle diseases. And we know very well for many years now the modifiable risk factors that could help prevent, delay, or change the trajectory of these NCDs. And of course, we heard earlier this morning as well that 40% of cancers, give or take, are preventable. So lifestyle and self-care is really important. So when we talk about self-care, it can get quite messy because it's a nebulous concept and can mean anything to anyone. Even in the literature, there are 139 academic definitions of self-care, and even WHO has 5 definitions of self-care, often interchangeable with self-management, prevention, and so on. So better than getting lost in definition, it may be helpful to look at conceptual models instead. Here's a very good example that we use. This is the self-care continuum, and this shows the ideal placement of an individual on the left of the continuum. So in a way, this is self-care in the context of resource utilization. If you're on the left, you could do what you want. You can go about your life and make your own decisions. If you break a leg on a skiing trip, you'll be somewhere in the middle, needing nurse support, analgesics, and so on. If you're on the right, you're incapacitated, and you cannot self-care. People with long-term conditions are somewhere in the middle. They could self-care, but they would need some medicine, they would need some input from health and care professionals. Another really useful framework that we use to conceptualize self-care is shown here by the 7 pillars of self-care framework. It talks about the person-centered set of activities that we can do on a daily basis to self-care. The key in the ignition here is health literacy, because without that, I think people may have misconceptions and they may not be able to follow what would be ideal or evidence-based. The second pillar, of course, is mental well-being. It's very important to have a good state of mind to start the day and to commit to wanting to live a happy and full life. The third pillar is physical activity, really important to be vital, to be able to preambulate and do what we want in life. And the central pillar of healthy eating, I think that's obvious to many people. We have pillar 5, which is avoiding risks, whether it's because wearing a helmet or a seatbelt or toxic people, or vaccinations, for example, or smoking cessation and so on. The 6th pillar of good hygiene practices, you could argue, has been taken for granted now. In the 21st century, we have hand soap. Not many people die from, poor hygiene. But in the context of modern living, you can imagine now limiting blue light before bedtime. This may be one example of why hygiene practices are important. And the biggest pillar of all is the pillar 7, the rational use of products and services. This includes prescription medicines, over-the-counter medicines, vitamins, minerals, supplements, traditional Chinese medicines. More than half the world use TCMs. We don't in the West, but they do. And even digital point-of-care test technology, and even parks and green spaces. So this is a very nice framework to explain self-care in a way that works for us. I wonder how I could change the slide. The slides aren't moving. Please, can we have the next slide? Thank you. So the first thing we did, we consolidated the existing definitions. Well, there are many enablers of self-care, and we understand, of course, lifestyle medicine folk, health restaurants, pharmacists, nutritionists, all of these are enablers of self-care. The first thing we did at SCARU is we consolidated all the existing definitions and frameworks, and we developed the self-care matrix. This is a unifying framework for self-care. It tells us self-care has 4 dimensions. At the micro person-centered level, you have the pillars, which you've seen. The second dimension is the social behaviors. How do you maintain these and sustain these self-care behaviors? The third dimension you've seen is the patient-centered resource utilization context, and at the macro level, we have the enabling environment, policies and so on. So this is a helpful way to look at self-care, and also recognizing that there are many different settings and sort of life course approaches. So from 5 to 105, self-care becomes important when you get older, the emphasis is different when you're younger, and we have to also remember there are different settings. So if you're in home and, as a child, it's more emphasis on hygiene, for example. When you grow up a little bit, university, it's more about heartbreaks, financial literacy, sexual health, and people my age are trying to basically manage stress and try to delay NCDs. And as we get older, our self-care needs change. So we're very lucky to establish in 2017 because the WHO published the first guideline on self-care interventions in 2019. And this was really a very special time for the self-care movement because everybody started, and all governments and policymakers began to talk self-care for the first time ever, really, in the policy context. So we've had the world self-medication industry rename themselves to the Global Self-Care Federation. We've had many infrastructures and sort of networks develop. The WHO published more guidelines. I'll come back to that in a minute. And we're all part of a coalition to advance the WHO resolution on self-care next year. And we're now writing for the BMJ and Lancet, which is remarkable given that self-care is quite a nebulous concept, if you recall, as we discussed earlier. So the WHO has done a lot of great work. They published a guideline in 2019, which had 24 recommendations on self-care for sexual health and reproductive rights. And these guidelines were updated in 2021 to include 39 recommendations encroaching on NCDs. So here now you have recommendations for self-management of hypertension, blood glucose monitoring, and so on, which is brilliant. They also developed 3 volumes of competencies frameworks, intervention classification document, and implementation guidance, and now there's a big emphasis on NCDs starting with oral health. And we're really delighted that we're part of the expert review group where the WHO on all of these. Self-care has become really trendy more recently. I mean, here there's a small snapshot from Google showing that the number of searches on self-care really has exploded in recent years. So incidentally, since COVID, I think it highlighted the importance of us looking after ourselves. And self-care in all its forms is becoming really important. You can see this huge peak starting from last year. And it's unsurprising given the number of declarations on self-care, recommendations that we have, networks, and so on. And in terms of megatrends, I think there's a resurgent interest now in looking at pharmacies as places where you simply don't go and buy stuff. On the contrary, it's a place where you go and you engage with the health and well-being, personal health records. There's e-pharmacy, telepharmacy, e-consultations, and all of these things. And in the UK, we've got systems and frameworks like the Pharmacy First scheme, which allows patients to access free medication for self-limiting conditions, including sometimes antibiotics, without having to see a GP. So, and that requires an interesting data sort of conversation. So these are really refreshing megatrends that we see, and they're becoming bigger. The other, of course, big megatrend, everybody's got a smartphone here probably, and we're all using apps, and a lot of these apps are health apps. Whether we use them or not is another story, although they're mainly consumer focused, not part of the NHS or the health service. We are seeing an increased use of symptom checkers, be it an app or a website or ChatGPT, for example. And of course, wearables. Many types of wearables are becoming cheaper, more accessible, and they're really sexy. And I don't know to what extent people use them to really change their health and well-being, but they're great to have, no doubt. And of course, the big category here is point-of-care tests, in vitro diagnostics, and CGMs and other sort of tools. So this is an important mega trend that we cannot sort of we need to keep aware of, and our obsession with self-quantification is growing. And we'll be discussing tomorrow, and I think others will be talking about the importance of, how quantified self and why that's becoming very important. And all of this really is inflating the pre-primary care bubble. So if you talk about sustainability in health systems, we want people to stay out of primary care if they can, or if they want to. And we can do this by promoting self-care, using technology, and so on, and health literacy. So these are interesting ways to democratize access to self-care interventions that can help keep people out of the health system because they're healthy. A really big mega trend, of course, then is remote monitoring. In the UK, we've got the at-home program. It has BP at home, which basically allows hypertensive patients to get a free blood pressure monitor from their general practitioner, and they're shown how to use it. And they don't eat the blood pressure monitor, but by monitoring the blood pressure regularly and by reducing salt intake and taking medication and good lifestyle, they can actually normalize their blood pressure, and they can then begin to see the impact of their behaviors on their vital signs, which is brilliant. I won't discuss this today because we're going to have a session on this tomorrow, but measurement is the heart of science, and there's a really big R&D priority at the moment to establish a measurement tool that can tell us, to what extent are people good self-carers. So there are a number of metrics that we can discuss tomorrow. We're developing Capitan, which is going to be measuring an individual's self-care capability across the pillars and other domains. But the biggest megatrend, and I think we all recognize this, is really an emergence of a new society in Romania also and around the world. And pretty much like the steam engine transformed life in Victorian England or the Industrial Revolution, and then we've seen electricity transform society, and we have seen how digital transformed our world. There's now going to be a non-linear expansion of possibilities with the pervasive use of AI, 3D printing, nanotechnology, blockchain. This is real. It's no longer a New Scientist magazine. And by 2030, we're going to look back and say, oh my God, the world is very different. So these are scary jumps. They're non-linear jumps, and these become more compressed. So whereas the steam engine took 100 years to transform, now it's going to be within the next 6 years. By 2030, I think everybody started using ChatGPT in 2019. So that's only a few years ago, and I think by 2030 the world will be completely, ambient AI. So because of this, I think it's important to recognize that health systems for prevention, to orient health systems, we need to be aware of that, and what we're calling is invest more in self-driven healthcare. So self-care with technology, and again, I'll discuss this tomorrow in more detail, but the idea is that we have a lot of silos of data, a pedometer on our phone, we've got our location data, our MasterCard transactions, and internet browsing history, wearables, all of that, blood pressure monitors, but we're not really using these data personally in the best way. So it'll be nice if we can think of a way to look at the plumbing that we need to make sure that we, the self-carers, can have the best data view without giving these data to governments or Google or corporations. So that we're looking at ways to make sure this is a sustainable model, because I wouldn't trust the NHS or Google or Amazon with a barge pole. If I'm going to give this system all of my data so it can give me personalized AI-assisted coaching, I want to make sure it's secure and unbreakable. But unfortunately, you always see on the news data breaches and so on, so there must be a way around that. Again, I'll discuss this tomorrow, but the future is already here. We have in China drones delivering your medications or your products. You've got now a lot of software as a medical device and AI as a medical device territory, and we have Gen AI, and the future of AI is going to be artificial general intelligence, which will make our AI today look like a Casio computer. So I think it is important to be aware of these megatrends when we talk about reorienting health systems in the future. So just to finish now, a couple of more slides, just to wrap up, to just say, self-care is important. It's been around forever, of course, the oldest type of care, but it's been rediscovered, I suppose, by policymakers. And because of this, we established the International Self-Care Day 24/7, 24th of July. So this is the World Celebration Day, recognized by the WHO. And since 2 years ago, the WHO now have a self-care month starting on the 24th of June. So 24th of June to 24th of July is self-care month, and the crescendo is 24th of July, 24/7, and that is International Self-Care Day. It'll be interesting to see what you guys will be doing on that day with your organizations. How do you celebrate self-care? And every year on ISD 24/7, it's not working, but every year we basically publish a celebration report to celebrate one of the pillars. This year we are in pillar 4, healthy eating. Next year will be pillar 5, there we go. So these are the pillars. We did a horizon scanning exercise, self-driven healthcare 2030, and every year we publish a report. And next year, this year is healthy eating. And by 2029, we would have finished all 7 reports. And by 2030, we will publish the 2040 horizon, looking at the mega trends for the next 10 years for self-care and digital. Most of you here are medical or allied healthcare professionals, and I think there's recognition that doctors and nurses and healthcare professionals can either be the biggest enablers or barriers to self-care. So we have a declaration now being published with our colleagues from Brazil on the importance of medical leadership in promoting self-care and not basically saying it as a work. There are many doctors who do not believe in non-pharmaceutical interventions, but if you really want to take prevention to the next level, you have to work with people, and we'll discuss later this afternoon with lifestyle and so on. So we have the International Self-Care Summits. They've been happening in London for the last 2 years. This year is going to be in Bangkok, next in 2028 in Brazil, and back to London in 29, and in 2030 we'll have the International Self-Care Summit in China. And that's going to be looking at smart cities, which could be dystopian, but we have to make sure they're not, technology, AGI, and so on. So self-care really is about digital self-care agenda for most. Notwithstanding inequalities, which we've heard about earlier, so we have to keep these in mind. But for most people, I think, here, and worldwide, I think the benefits of self-care are huge. Governments and people are taking notice. It's not new, but I think they'll be reminded of the importance of self-care. Health literacy and personal empowerment are the key in the ignition. And on that, I think self-care really is about choice. We should never force self-care or vaccinations or any treatments on anyone. Self-care is really about personal empowerment and choice. So when we do talk about vaccinations, or the better word is if they immunize, and all of the prescriptions, it's really about making sure people want to have them, and therefore not manufacturer's consent, but it's actually fully informed consent. And we want to make self-care sexy and prevention sexy, so people want to adopt self-care as a default. So, and reimbursement models, of course, currently are very geared towards activity, but in the future we hope that they'll be based around outcomes. So the healthier you keep your patients, the more funding you'll get from government, as opposed to the more activity you do, the more money you get. And just to conclude, then, future health systems are preventive by design. It's inevitable now that we have more prevention and behaviorally enabled and digitally mediated for most. And self-care, we hope, it will be recognized as the connective tissue to bind it all. Thank you very much for your patience, and apologies for the slide issues earlier. Thank you. Oh, pardon me. Right.
Thank you very much, Dr. Austin. We are very pleased to introduce now from Preventive Committee of ESGO, Claudia Marchetti. She is online. Thank you very much. Claudia, are you online? Do you hear us?
Yes. Can you hear me?
Welcome, welcome.
Okay, I'm very pleased.
We are very pleased to
It's my pleasure.
have you here with us. Next year, you promised me already that you'll be here.
Yes, I will be more than pleased to stay with you next year live.
Okay.
So let me share my slide. So
Claudia Marchetti is associate professor, gynecologist, like me. And she represents European Society of Gynecologic Oncology.
okay, can you see my slide?
Yes, thank you.
Okay, perfect. So first of all, thank you again for the invitation. I'm very pleased to stay today with you. And I really feel that this is one of the ways in which we can improve the prevention of gynae cancer in our patients, in our women, because they're women. So I work in Rome at the Gemelli Hospital. I am a gynecological oncologist. I am involved in both therapy of gynae cancer and prevention, especially hereditary cancer. And I'm also part of the ESGO Prevention Committee. So I work with them since 3 years, and I have to admit that it's very active. And so I have been asked today to discuss with you something about the Prevention Committee within the European Society of Gynecology, so in Europe, and also some new vision for prevention, especially secondary prevention in ovarian cancer. I will try to be quite short. So about the ESCO Prevention Committee, this is something that started in 2019. It's a group of experts and research teams working in this field all around Europe. So we have several representations across Europe. We started in 2019, and now we include more than 80 experts in several things about prevention. So vaccination, a lot of the work you will see is about cervical cancer, so colposcopy screening, but also prevention of endometrial cancer, ovarian cancer, hereditary cancers, and also rare cancer. And also the prevention work a lot during the COVID pandemic. So now many are included and many others work with the experts. So there is a lot of activity. The aim is to fill the gap and so give new evidence for prevention, try to be the most updated, and also providing evidence on the topics related to also prevention of preventive disease, especially in cervical cancer. Of course, another important point is bridging the gap between East and West Europe. And so we try to share the expertise of the health professionals with colleagues in low and middle income countries. So there are many educational activities and virtual conferences, webinars that are done with this main in mind. We work in several ways. We try, first of all, to publish. You will see that research is the main focus of the prevention committees, because to change the things, you have to be reliable. And so you have to demonstrate. And the job of many of the experts within the prevention committee is to produce very high level research that is shared with the members within the ESGO society, but also all around the world. We also aim to increase public and governmental awareness of gynae cancer, advocating prevention strategies through initiatives like Engage. Maybe you are familiar with that. And also we collaborate with many other professional societies, with advocacy organization. And it's important that within the prevention committee, there is a passion. So we really want to be close to our patients, try to not only to understand and to publish and to know the better we can, but also to know which are the needs that they have. And also we have tried, and you will see, to contribute to the cervix cancer elimination in Europe in line with the WHO program for 2030. About the members, now the head of the prevention committee is Emma Dura, but until February this year it was Murat Gültekin, which is very, very involved in prevention activity also in Turkey, where he came from. Now Helma has a very important job, which is to do as good as Mora did, and I'm sure you will succeed. And you see many of us are the members of the prevention committee. And then there is a bigger network with other people which are related with the members of the prevention committee or within the ESGO society. To be sure that not just the members of the prevention committee, but also the ESGO members can be involved in these interesting activities. These are the members of the prevention committee. You will see after me Nicola Bizzarri, which is discuss with you about cervical cancer. I think it's also really involved. About the publication, we did a lot, because 22 publications in these 5-6 years is a lot, but also the quality of the publication is very, very high. More than 20 publications in very high index paper journals, so we are very happy for that. And these publications cover different aspects, such as screening strategies, HPV-related prevention, and also management of preventive disease. And you see, we start in 2020. The field of cervical cancer is, of course, the one that we have developed the most. We have many important experts like Mara Kjörgu, which you know. She is very involved in prevention of cervical cancer in UK, and she studied a lot. So we work with her, and I think she was very crucial for many of these publications. And the topics are HPV-based screening, HPV vaccination, and colposcopy standards. And you see, 2026 paper than we have in 2022. And here we cover also other topics. And also we were able to produce some consensus statement, some consensus recommendation in the field of cervical cancer, but also in the field of other cancer. And you see then in 2023, we have some other publication about HPV vaccination. We have a consensus statement for colposcopy, so we have tried to standardize the approach of colposcopy. And it's important to see that there are several members within this publication, several co-authors, many of these from East and Middle Europe, because we really, it's first of all, because cervical cancer is very spread, and also in these countries, and we also want to be keen to all the countries involved and to produce some recommendations which are applicable everywhere in Europe, not just in several or in few countries. And I think we succeed. Then we have some other, you see other publication, and you see the papers, the journal in which we publish are very high quality journals, which is another of our point. And then we have some other topics that we want to develop. And so this year we published this paper, in this case, not in the field of cervical cancer, but in the field of ovarian cancer prevention. This is about opportunistic self-injectomy. And you see, once again, a collaboration of several experts. We produce this recommendation to provide a practical and feasible preventive approach for ovarian cancer in the general population, so not just the high-risk population. We publish also in rare cancer, in vulvovaginal disease, so there are some experts especially dedicated on this field. And also, as I told you before, we dedicated some of our efforts in the time of COVID to see how we can deal with this problem in the COVID time. And I think it was really appreciated in the research scientific community. Now we have some other points. I am mainly involved in hereditary cancer. And so we work in 2025 in two statements. One is about an ethical consensus statement for prevention of endometrial cancer in patients, women with Lynch syndrome. We worked a lot. We have very good experts also from someone from UK. We discussed a lot sometimes the topic, and then we came out with the 34 statements. This is going to be published very soon. And also we have another statement about ovarian cancer in high-risk population. You see many experts, but also many fellows. What I missed to mention is that when we work, not just we work with experts, but also we want to have with us some fellows, so young people, because we really believe that we shouldn't be alone, and we should give our experience, our expertise to the younger generation, and they work with us while we are producing this statement. And some of them are very, very good and became even better statement by statement. So we are quite lucky to have them with us. And the statement is ready, and we are finalizing for the submission. You will see this, I think, by the end of this year or middle of this year. Another important topic is a virtual conference or on-site professional conference. And I would like to see some of you online or maybe present on site in the next event. One of the key initiatives is especially to organize these activities, these international conferences, because we want to promote the best practices. And we have one, it was online, and it was specifically tailored to Africa and limited regions, so outside Europe. And we had more than 500 attendees from more than 100 different countries and more than 30 panelists. So we are very committed to this issue. We have an on-site conference, the fourth for the Prevention Committee, which was in Belgrade in Serbia, September last year. It was mainly focused on the anogenital neoplasia, and many of us were involved in several activities. And it was a nice moment to stay with our colleague from Serbia, in general from ex-Yugoslavia. And it was very, very productive. And I felt when I was there that it was important for us and for them to stay connected, because we can start new projects if we stay connected as much as possible. And then we have several prevention webinars, so online. We try to have at least 2 per year, and also we try to be also related with other European societies to also have many people connected and so share our activities and our ideas. And you see, normally we have more than 150 attendees and more than 300 registered colleagues. So it's really a way to stay connected. In the next future, we will have several of them. We will have one about sapingectomy in September, and sorry, April, the 7th of April. You are more than welcome if you want to participate. And there are more than this that are coming in next month. So I think that the future really depends on this international collaboration. We have to integrate our knowledge, our technologies, and also our approach in our countries that need to be shared with other countries to be sure that we can come out with the best recommendation. And I'm also very pleased to stay here today because this represents an opportunity for us from the ESCO Society, and if you want, for you to stay connected even more. And in this regard, I think that one of our member in the ESCO Prevention Committee is Mihaela Greore, which is from Romania. She's also very active, especially in the cervical cancer field. So I think that already ESCO Society and Romania are starting to collaborate very well. So moving to the other topic that I was asked to discuss with you, it is about prevention of ovarian cancer, mainly secondary prevention. Primary prevention normally focus on risk reduction, while in secondary prevention, we want to screen our patient and try to have an early detection of cancer. And I think among the gynecological cancer, ovarian cancer is the most unfortunate because it's differently from cervical cancer, breast cancer. It's very complicated to have any kind of prevention. The truth is that we are not able to screen our patient nowadays, not in the general population, neither in the high-risk population, which is, of course, a problem. But I think we are trying to do a lot. And of course, with primary prevention and risk reduction surgery, we are starting to decrease the occurrence of ovarian cancer in several countries and all around the world. About secondary prevention, I think we are doing something. And I would like to share with you some new possibilities, not really in the guidelines, but in the near future. And we have to work on that to really improve the health of our women and to see the decrease of ovarian cancer occurrence. And I think two are the points that need to be discussed nowadays and that will develop the next future. First of all, the possibility of population-based screening. We know that traditionally genetic testing is focused on BRCA1 and BRCA2 genes, and the eligibility criteria are mainly based on personal or family history criteria, which is good, of course, it's better than before, than the past, but now we know that there are several limitations, particularly up to 50% of ovarian cancer gene carriers do not meet family history criteria, and also we may miss up to 70% of women with Leach syndrome if we only based testing, genetic testing on family history criteria. So we understood in the close past that we have to change the way in which we test our patients. And the thresholds are decreasing. Now, in the past, we start with a 10% threshold, which was the threshold, patients should have a 10% risk of being mutated on BRCA1 or BRCA2 genes to receive the test. So it was quite high. Then it was decreased. And now we want to move the population-based tests. So not family history, no clinical criteria, but the overall population. And there were some trial investigating these possibilities. Over the last decade, several initiatives have moved from the theoretical discussion to the real-world implementation. In Australia, there was the DNA screening test study, which evaluated more than 10,000 adult male and female. They were tested for BRCA1 and 2 from Lynch genes and also for familial hypercholesterolemia genes. And it was found that 1 out of 50 individuals carried a variant of one of these genes, and 70% of these would not have met standard testing criteria, which suggests us that we should move beyond genetic and family test criteria. Then there was the SCREEN project, which is from Canada. This represents one of the first real-world implementation study for population-based screening. In this study, which was launched in 2017, this is women and males, so they can choose to participate, and it is self-paid, so they have to pay for the test, which is a saliva-based test for BRCA1 and BRCA2 genes. It is currently ongoing, but some preliminary results were presented in 2021. And these are very important because in more than 1,000 people, individuals tested, approximately 2.4% were positive for BRCA1 and BRCA2 genes. And so about 1 out of 42. And even more importantly, 40% of them had no significant family history. So once again, we see that family history is not enough to tailor genetic testing. And finally, there is the PROTECT-C trial, which is from UK, from United Kingdom, from Ranjit Machanda, which is a member of the Prevention Committee and now is a member of the ESGO Council. This project is starting in this month, so in 2026 in the UK. This is the next step in population-based germline test. Once again, there is the saliva-based test, not just for BRCA1 and BRCA2 genes, but also for other genes involved in the occurrence of ovarian cancer, like RAS51, PALB2. And here the primary endpoint is to compare the pathogenic variant carriers identified to the standard family history criteria to those who are detected through the population-based screening. And also they want to see if this is sustainable for the NH system, because in this case, this is not self-paid, but is paid from the NH system. So let's see how this will deal. And we need 24 months for the accrual, and the study will conclude 24 months after the final follow-up meeting. So overall, 8 years. And finally, what we'd like to underline today is the possibility to identify patients at risk of developing ovarian cancer or with very early ovarian cancer through the pap test, to the pap smear. And I think this is quite a revolution. We know how the ovarian cancer is supposed to develop. We know that high-grade serous, regardless of the BRCA1 or BRCA2 mutation, is now understood to originate primarily from the distal fallopian tubes, and then the cells move to the epithelial surface of the ovaries. And so it is possible that some cells from the tubes, more or less here, may move from the tube to the uterus, and then we can find some of these cells in the cervix. So we can collect through the pap smear. This is the hypothesis. And on this basis, it has been thought that probably we can collect the pap smears from the cells in the pap smears and find some abnormalities in these cells. And several molecular strategies have been developed with this issue. And they want to explore whether pap smears can really be purpose for early detection of high-grade serous ovarian cancer. There are 3 studies which have tried to study in depth these possibilities. One is the pap dream test, which is based on the analysis of DNA methylation. Here, this was a small retrospective study, investigated 43 women, 18 ovarian cancer cases and 25 cancer-free controls. The test uses these pap smear samples to detect the epigenetic alteration in the cervix. And in terms of performance, it was quite good for the specificity, because we have a 99% of specificity in identify this DNA methylation, but the sensitivity was not very high, 50%. So this is one of the possible approach, not the best, but this suggests that it is possible to find something in the pap smear. Then there was another approach, which is called the pap-seq. Once again, a retrospective case control study. In this case, more than 600 patients with endometrial ovarian cancer were compared with more than 1,000 healthy controls. In this case, it was not investigated the DNA methylation, but the specific mutation in 18 genes or an antibody which are supposed to be related with endometrial and ovarian cancer. cells were collected from the endometrial cavity and from the pap smear. So two different kind of samples and of technology. And overall, it was found that there was a quite high specificity very high, close to 99, 100% for the discovery of endometrial cancer, especially when we use the brush in the endometrial cavity, while the sensitivity was lower for ovarian cancer detection. And in this case, also blood samples were collected. And when together, the brush from the cervix and from the endometrial cancer were put together with the blood sample, we had a sensitivity of 63% in identifying some specific mutation of ovarian cancer. So once again, we have quite good sensitivity, but not very high, a very high specificity. This approach is supposed to be promising, but we should improve somehow. And if possible, the best way to go for this kind of approach, so with the pap smear, is the EVA test, which is quite new. This is from some Italian researchers. We are happy of that, from Milan, from the north. What they have done is a new test, which is called the EVA test, which investigated not the DNA methylation or the specific mutation, but the genomic stability in cervical cancer samples. We know that ovarian cancer has a very high genomic stability, and so they want to see if this genomic stability from ovarian cancer can be collected in cervical samples. And what they found in these samples, they extracted the DNA and analyzed the copy number alteration. They found the change, and also they had a sensitivity of 75%, which is higher than the other test, and a specificity of 96% in identify this genomic stability in the pap smear. And also, I think it's very important that with this approach, they were able to found molecular changes related to ovarian cancer in this pap smear, which came from patients, and the pap smear were collected before the occurrence of ovarian cancer, even 9 years before the occurrence and the real diagnosis of ovarian cancer. So this suggests probably this approach is quite good. Of course, this should be validated further, because it was initially validated in 66 patients with ovarian cancer compared with the 77 in the contrast. But this really suggests a different biological approach and suggests it is possible to identify this patient very, very soon, eventually 9 years, the real occurrence of ovarian cancer. And now there is another project ongoing, which is focused not on the overall population like the one before, but in the high-risk population. So my conclusion is that, of course, we have to consider the prevention of ovarian cancer. We have to do risk-reducing surgery, because it's very crucial nowadays, not just for BRCA1 and 2 genes, but also for PALB2, NAT51C and D, and DRIP1. But also we have to look at the future, and probably the future could be the population-based screening, and we were able to identify more women than now, and so to prevent more than now. And probably we also need to identify very early the ovarian cancer, the high-risk ovarian cancer. And I really believe and hope that PET-based test-based DNA analysis would be helpful on this regard. Thank you.
Claudia. Thank you, Claudia. This was only the first step in our collaboration, I hope. And thank you very much again. We move on because we already very late. If are any questions from the audience? No? So we can invite your colleague from the same ESGO Prevention Committee, Associate Professor Niccolo Bisari. It's online now with us. We hope so.
Yes.
Hi, Niccolo.
Can you hear me? Can you hear me?
We can hear you, but we don't see you. Just a moment. It took 1 or 2 moments to establish, yes, the contact. Thank you very much. Welcome to the International Congress of Preventive Medicine.
Thank you so much. It's great to be here
You
with
have
you.
to promise me that next year you'll be here. Let's begin.
Sure.
Yes, okay, fine. Thank you very much. Let's go.
Thank you. Okay, so let me share my screen. I hope you can see that.
And share it with us. Thank you.
Thank you. So I would like really to thank you for the opportunity to discuss and being with you virtually. I'm very sorry not to be there in presence. We had multiple commitments this week, so it was really, really tough. But we arranged with Claudia to be there next year, and we will be there face to face. Now, it is my really pleasure to introduce you a topic that is also been part of discussion and studies from the ESGO Prevention Committee. And this is the role of HPV vaccine after gynecologic cancer diagnosis and treatment. We really believe this is an important topic because it's quite a hot topic. Today, many gynecologic oncologists and many general gynecologists recommend, prescribe HPV vaccination after cancer diagnosis, in particular gynecologic cancer, and in particular cervix cancer diagnosis and treatment. But the question is whether this is useful or not. Before starting, I always want to give a big thought to our mentor, Professor Giovanni Scambia, who unfortunately prematurely passed away last year. But his legacy is continuing very strongly, and we are very, very committed to implement all his teachings. Just a very brief touch that we all know that HPV vaccination significantly reduces the risk of invasive cervical cancer. This has been, of course, demonstrated. And when I see this study from New England Journal of Medicine, it's obvious that there is a correlation between the age at vaccination and the outcomes of risk of cervical cancer development. You can see that all the individuals were vaccinated before 17-year-old or in general in the pre-sexual time, there is no risk of cervical cancer development or minimal risk. So this is very important when we also think about the recommendation of HPV vaccination in, let's say, young adults or adults, women and patients. We know that in general for preteens, let's say, population, the HPV is strongly recommended because it gives a long-lasting immunity with very, very low risk of adverse events. In terms of safety, it's been well described that before for 4-valent HPV vaccination and now for 9-valent, the risk related to the vaccination is very low. And in general, there are minor adverse events. You can see here the most common is syncope or injection site reaction or dizziness. Another study shows the same with the famous, let's say, autoimmune Guillain-Barré syndrome being described in this Australian study in 0.05% of the vaccinated cohort. Regarding a 9-valent HPV vaccination, again, there is the same safety profile. So the safety concerns are very low. And this is an added point in order to recommend the vaccination. So the big question is HPV vaccine after gynecologic cancer diagnosis and treatment. What is the role of prophylactic HPV vaccination after the treatment of gynecologic cancer in reducing the risk of HPV persistent or recurrence and reducing the risk of cancer recurrence? This was the big question that we asked ourselves in the ESGO Prevention Committee. And actually, this comes from evidence based on the pre-cancer diagnosis. In fact, we can see here, this is a systematic review and meta-analysis, and there are many studies that now show that HPV vaccination after treatment of HPV-related disease, in particular pre-cancer disease, there is a reduction on CIN2 plus recurrence, AIN reduction, recurrent respiratory papillomatosis reduction. So these were all significantly reduced in patients who had HPV vaccination before or peri-treatment for pre-invasive disease of cervix or vulva and vagina. There was no difference in VIN and VINE reduction and no difference in anogenital warts. Similarly, very recently, our colleague Elmar Jura, who is now actually the chair of the ESGO Prevention Committee, showed that among females who participated in clinical trials looking at the efficacy of HPV vaccination, in particular 9-valent HPV vaccination, those who had prior HPV vaccination before the treatment, excisional treatment for cervical dysplasia, there was a reduced incidence of subsequent cervical and lower genital tract dysplasia. This is quite important. So it supports the use of HPV vaccination in before or after the treatment of cervical dysplasia, or in general, lower genital tract dysplasia. So with this background, we were asking ourselves, but yes, this is okay for pre-invasive disease, but what about patients who had already been diagnosed with invasive cancer, gynecologic cancer in particular? We all think about cervical cancer. So we decided to have a thorough analysis of the current evidence within the ESGO Prevention Committee. And we came out with this ESGO Prevention Committee opinion, which was published now 1.5 years ago. We realized that actually the evidence at that time, of course, the evidence of the use of HPV vaccination in the setting of HPV-related gynecologic cancer was absent. There was no evidence at all. The ESGO Prevention Committee opinion was to counsel the patients as any HPV related non-gynecological cancer and non-cancer patients, suggesting vaccination according to patient's age and prognosis, knowing there is a decreased efficacy age. So the conclusion was that we still should counsel patients and women as we do in our daily practice, despite the diagnosis of cervical cancer. Studies on the use of prophylactic HPV vaccine were strongly needed. So after that, we from Gemelli decided to make a retrospective studies, which was presented at ESGO 2025 Congress, so after the publication of the ESGO Prevention Committee opinion. And we looked at 93 patients who underwent, were diagnosed with the cervix cancer and underwent fertility-sparing surgery. The question was whether the HPV clearance in the follow-up was, let's say, different on patients who underwent vaccination at time of treatment, or who compared with patients who did not have vaccination at time of treatment. Basically, 35.5% of patients did not receive vaccination and 64.5% were vaccinated. This is the breakdown of the patient's details. We had a median follow-up of 17 months, and the results showed that HPV clearance at first post-treatment HPV test was not different between the two groups. So in our cohort, this was the result. But I have to say that there are many limitations of the current study. particularly the first, of course, the sample size, which was very limited. You see 93 patients in total. And there was a huge heterogeneity in the timing, which is described in this picture, the timing of HPV testing and the timing of vaccination. So basically, we wanted to have a picture of what was happening, but we have to also be cautious about giving message that it's not effective, because this data is really, really, let's say, preliminary. At the same Congress, which was last year, there was another poster which was presented. Again, I want to highlight these are only posters and, let's say, presentation at congresses, but there is no paper still published on that. This was a Spanish group which wanted again to look at the efficacy of HPV vaccination in cervical cancer patients. In this study, there were only 59 patients analyzed, and there were a very small number of patients who were vaccinated. You see that 4 patients were vaccinated. And in this small group of patients, there was no difference in HPV detection after the cancer treatment, but there was a trend toward protection against development of vaginal and vulvar squamous intraepithelial lesion. So again, a trend, but the numbers are very limited. For this reason, again, we decided with the ESGO Prevention Committee, in collaboration with PERCH Group, which is an international group or study group against to study against HPV, let's say, infection, and to eliminate HPV infection. We decided to make a collaboration and develop a survey which wanted to make a picture of the prophylactic HPV vaccination in the gynecologic practice, with a particular focus on different scenarios. This is the results of our survey. We managed to capture 149 responses from gynecology and gynecologic oncologists, and this was used through the ESGO database of ESGO members. These are the characteristics of the responders, but let's go to the results, which are quite interesting. This figure shows the results of different scenarios, clinical indications, according to different ages. It might appear a little bit difficult to read at first glance, but I just want to highlight that this is the when gynecologists believe that the HPV vaccination should be recommended in different settings. And if we look at patients with cervical cancer before, during, or after treatment, we can see that more than half of gynecologic and gynecologic oncologists think that these patients should receive HPV vaccination, prophylactic HPV vaccination. And if we look at how many of the responders actually prescribe and recommend HPV vaccination in this setting, in cervix cancer, you see that about 60% of responders prescribe and recommend HPV vaccination up until the age of 45, and 42% above the age of 45. So almost half of respondents still prescribe and recommend HPV vaccination, even in older patients. This is the, let's say, discrepancy between ideal and real-world experience in different settings. We also wanted to capture the reported barriers of HPV vaccination recommendation in gynecologic oncology care, and we realized that the vast majority of respondents believe that fake news and social beliefs about HPV is the most important barrier. And secondly, there is a lack of education materials for patients, followed by lack of time during consultations. So these are the main barriers. We decided to conclude that this survey showed that HPV vaccination is frequently recommended beyond established indications, revealing some level of over-indication of HPV vaccination based just on expert opinion. At the moment, ESGO emphasize caution because the evidence is is very scanty, but we need further studies in this respect. So I just can conclude that, and I want to highlight that I want to thank all the group from ESGO Prevention, Perch, Joanna Kacperczyk, who was the first author of this paper, Murat Gultekin and Mark Arbin, who were really involved. And this is the really a start of a part of studies that are really needed in this setting, because at the moment we just can conclude that the evidence to support the use of HPV vaccination, of course prophylactic HPV vaccination after gynecological cancer diagnosis, is really poor. The safety profile, despite everything, has been proved. And for this reason, the HPV vaccination is highly recommended in the adjuvant setting, but still based on expert opinion or personal opinion. This our ESGO European survey showed that it is common practice to recommend HPV vaccination in different settings and at different age, but further studies are recommended. Thank you so much, really. And I want to thank all
Thank
the
you, Nicola.
committee.
Just a small and short question. What do you think about HPV faster program, or even faster? How do you implement in Spanish this program that begins to start in Europe?
Sorry,
HPV
that
faster,
I did-
HPV faster, even faster program? No, okay.
The faster program, you mean in vulnerable populations?
No, it's a program dedicated to eliminate cervical cancer even faster than each country programmed to do that. And we are limited now in Romania only for jail women. And I wanted to know how you are doing in Spain.
In Italy, you mean?
In Italy, sorry.
Yes.
Sorry.
The problem is that
The study was Spanish, sorry.
The problem is that unfortunately still there are some barriers and resistance, particularly from the mothers of the teens or the preteens that need to be vaccinated. We need to really work on communication and information to the mothers and in general the parents of these boys and girls, because that is where we need to act, and of course we need to implement, because still in our country the uptake of HPV vaccination is absolutely not 100%, but it's about 50-60% in the last couple of years. So we really need to work on this and show the results that this provides.
Thank you very much. From here, from Romania, and
Thank you.
we move on. Juliana Desa, Policy Officer of European Cancer Organization. One region, one goal: accelerating HPV-related cancer elimination in Southeast Europe.
Thank you so
Please.
much. And just asking to have my slides, please.
One moment.
So while we get the slides, maybe I can just start my presentation. And first of all, thanking so much the Romanian Society of Preventive Medicine to having us here. Considering that we are already running a bit late on the event, and it's a quite difficult task for me to speak after so many knowledgeable experts, so I hope my presentation encapsulates some of the topics we already discussed. And as Professor Roxana said, I'm a policy officer at the European Cancer Organization, and today I'll be speaking about the work we do on eliminating HPV-related cancers in general, but also in particular in the work we do in Southeast Europe. And I hope that my presentation will inspire you. Basically, I will present some of the tools we developed at the European level to inspire countries at the national level to make progress. So my presentation won't be very technical. It will be more a practical toolkit on advocacy. So after my presentation also, if you want to discuss how can these tools be useful to the work that you do in Romania, but also if you have here from other countries, I'm very happy to connect and discuss it further. But just before I talk about HPV-related cancers elimination, just to give a bit of context on who is the European Cancer Organization, we are basically an umbrella federation of 40 member societies and 21 patient advocacy groups. And our mission is indeed working together to build consensus and achieving improvement in cancer care. And that really resonates with the work we do on HPV cancers elimination. So here you can see our 40 member societies. I will highlight here the European Federation for Colposcopy, as we have Professor Maggie with us here today, the European Head and Neck Society, with whom we also collaborate a lot on our HPV work, ESGO, the European Society of Gynecologic Oncological, that we just had two amazing speakers from there, and of course the IPVS, the International Papillomavirus Society, with whom we collaborate very closely. And of course, we need to do things with patients. So we have 21 patient advocacy groups working with us. And I will highlight the patient group from ESGO. ESGO Engage, the European Network of Gynecological Cancer Advocacy Groups, with whom we work very closely. And we already heard here from some of the speakers on the WHO strategy for elimination of cervical cancer, and that's exactly how our work started. So the story began in 2018 when WHO was designing the global strategy for elimination of cervical cancer, and we, the European Cancer Organization, we believed that we had an important role to play on bringing people together, putting everyone in the table. So we brought together the ESGO group, policymakers, stakeholders from different medical professions, because we wanted to make sure that everyone was on the table designing the strategy. And it was exactly in that moment that it was a truly moment of expression of multi-stakeholder action. So we included, of course, multi-stakeholders, professions. We included the dentists, organizations representing migrants, GPs. So we made sure that everyone was sitting on the table. And after that, we set our HPV Action Network that in the meantime you can see that evolved not only for HPV but also hepatitis B action. And our network is shared by Professor Daniel Kelly from the European Oncology Nursing Society and Professor Margaret Stanway from the International Papillomavirus Society, and also on the hepatitis side by Professor Patricia Carrieri from the European Association for the Study of Liver. And also we have now included vice chairs from our young cancer professionals. So now we also have Emil from Bosnia as a vice chair of our network. So later on in my presentation, I will include a QR code, but this network is open not only to our member societies, but to all of you. We organize meetings on a biannual basis, so you all can join and be part of the discussions. And we really believe on the power of Europe working as one, and was exactly in that regard that after the announcement of the WHO Global Strategy for Elimination of Cervical Cancer, we started a lot of our work among producing reports, organizing events with policymakers, mainly at the European level in the beginning. So we started our advocacy efforts. And in 2021, we managed our big first success. So in 2021, as you might be aware, the European Commission launched the Europe's Beating Cancer Plan, and for the very first time, there was dedicated funding to a flagship mission of eliminating HPV-related cancer, cervical cancer, but also others, as you know. But we continue to advocate for other initiatives, and we already had the pleasure to hear from David from IARC and also the Romanian ambassador on the 5th European Code Against Cancer. And in my presentation, I would like to highlight something that was already mentioned, but for the very first time, it was inclusion of vaccination of both girls and boys against hepatitis B and HPV, which was a great success. This is a very important tool that in a very summarized way, policymakers can have information. So I would encourage all of you to use it in your national work. And then also another success was the new Council recommendation on vaccine preventable cancers. We believe that mainly the role of Europe at the national level is to support implementation, and we believe that that can be done first through measuring progress, and that means identifying where are the inequalities and then target actions accordingly. And for that, there are some tools at the European level that are designed and very useful to be used at the national level. Then to provide countries best practices and necessary guidance. So it's very important, this conversation between countries. We just heard from Maggie in Scotland. This is something that we really encourage at the national level. And of course, at the last and ultimate goal, to increase the mandate of the European Commission, but not only, also the sense of accountability among national governments. And now I will present some of the tools that we've developed in the past year. The first one is the HPV Prevention Policy Atlas 2025. This is an initiative led by the European Parliamentary Forum with support of the European Cancer Organization. You have a QR code there, so if you want to explore it and use it afterwards, I would encourage you to scan the QR code here. But in our advocacy work, this tool is really proving as an important tool because it's very easy for policymakers to take it and show, in particular, look, Romania is there in terms of HPV prevention policies. We are lagging behind, and of course, we need to compare with countries overall, but it's always very strong if we compare with neighboring countries, because, for instance, if we can show to Romanian policymakers that Turkey, which is very close to Romania, did something great in terms of HPV screening and it's working there, that message will resonate more with policymakers. So I would really encourage you to explore this tool, and of course, afterwards, if you want to discuss it with me, very happy to. Then another tool that we developed end of last year was a report on the status of cervical cancer screening programs in Europe. So what we did in this report was really to analyze in depth what's the differences between the screening programs in Europe. And after, you will find some recommendations. The recommendations were first on equity matters. How can we ensure equity in the cancer screening programs? Then building effective screening pathways. And as we already discussed a lot here today, the importance of registries and quality assurance. For here today, I will focus on our recommendations on equity matters. So our first recommendation is the integration of HPV self-collection to ensure more equity. Then the implementation of targeted outreach. As we know, different populations, different communities require different communication strategies, so we make sure that we are reaching them. Then the importance of strengthening the patient-provider relationship, the importance of engaging communities and local leaders, because we need trusted messengers to ensure that people are committed with the HPV prevention. And then the importance of identifying barriers. That barriers can be social, can be cultural, can be structural factors that are very linked to society issues that they cannot be ignored, and we need to address them. And also here you have the QR code for the full report. The new tool, that's actually you're the first ones knowing about it, it's the new ECO Good Practice Guide on HPV vaccination. So this tool will be launched in a month at the European Parliament. It will be a hybrid event, so even if you want to attend from here, there's a possibility. If you follow the European Cancer Organization on our social media, LinkedIn, Instagram, you will find information about the event. And basically this ECO Good Practice Guide on HPV vaccination, in a nutshell, is basically 1 to 3 steps on what countries and governments should do to ensure that the commitments on HPV vaccination go really to practice and there's truly implementation. So basically, it's providing a practical blueprint for national policymakers, translating their national commitment into action, and it aligns stakeholders across Europe on HPV vaccination priorities, and the ultimate goal, of course, is to support countries in achieving higher vaccination coverage rates, covering both boys and girls. This is a very important aspect of this guide. So stay tuned with us. It will be launched very soon in a month, and I really believe it will be also an important tool here in Romania to advocate for change, because it's not designed to be another lengthy report with a lot of pages. It's a concise tool, so I hope you'll find it useful. But we cannot stop, and our advocacy continues. We know that there was a political momentum on cancer, but we want to make sure that the political momentum continues. So we regularly organize events with policymakers in Brussels. So this is an event that we organize at the European Parliament with a lot of members of the European Parliament very committed, including Romanian MEPs that are very committed with the cause of HPV. But as the title of my presentation, in the past years, we are doing a lot of work in the Southeast Europe region, and our goal here is really to put everyone in the same table, countries to exchange good practices, what's working, what's not working, what are the challenges. And the picture you see here was an event we organized in Sofia in the Parliament last year, the first Southeast Europe conference organized by us, and actually we are organizing already the second one, and the second one will be here in Bucharest. So I have also here the QR code if you want to register to the event. This event will be organized with the European Cancer Organization, but also together with ESGO and the Romanian Football Federation. And I would say it's an unusual stakeholder to organize a health conference with. But as we know, misinformation exists. We need to ensure that people trust HPV prevention. So football and sports in general, it's proving to be a very effective way to reach people. So the event will be held at the conference room of the Romanian Football Federation. You can find here in the QR code already the early details. And I think now the title of my presentation, One Region, One Goal, it's more clear. So I hope that I will have all of you there online or in person here in Bucharest on the 11th of May. Also here, a call to action to all of you. So right now we are developing 2-pagers with basically a summary of these 3 tools I presented, that being the Atlas, where are the countries, and then recommendations on cervical cancer screening, and also recommendations on HPV vaccination. So here an invite to all of you. If you want to be one of our ambassadors here in Romania and really support us in the design and development of these 2-pagers, there will be a 2-pager on Romania. So my email is here, so if you want to get in touch with me and be part of this project, we would really like to have you on board. And this is just the last QR code, a lot of QR codes, if you want to be part of our HPV network and participate in our meetings and be involved in all our discussions. And that's it. Thank you so much.
Thank you. Thank you, Juliana. Your energy is wonderful. And Romania has a job for European Cancer Association for next 20 years. So thank you. Let's see what about Albania. And I invite Professor Inver Roș to present his speech. Just a moment, we don't hear you.
Yeah. I'm very happy and delighted to be here and to say many thanks to Professor Roxana Baimiția for her invitation to be in this such good organized Congress here. I will present here something that overview of public health in Albania and regarding to some main indication. Maybe you know Albania is in the southeastern of Europe, in the coastline of Adriatic Sea, which here I can say here that one of the main data, now we have the mean population age is 42.5%, which is uncommon for Albania in 30 years after the communist regime collapsed. In the 1990, it was 23 or 24 years, the mid-age, now is 42.5 years. And rapid aging, which is more than 20% of over 65 years. And early dependence ratio is close to 30%. And most of around 32% of population lives in Tirana. This we have some data about demographic changes in Albania, which close to the epidemiologic changes, transition in Albania in last 30 years. Here, You see here the life expectancy in Albania. It has been 75.7 for male in 1990, and now it's 78.7 in 2021, and for males it was 69.8 and 73.6 in 2021, and is predicted to be 83.1 in 2050, and for female, and 79.7 and for male. I think that beside this, Albania, has a very high, life expectancy, and it's based actually by the Mediterranean diet. And as we mentioned here for the first presentation here, we have these social networks in Albania, social support. So we enjoy, we talk. So the level of lonely population here to live alone is low. But on the other hand, I like to say that for the first presentation that we have to avoid the toxic people, which I got the point from our colleague from British, I think, from London. And here, the fertility rate was declined rapidly. And from the 1990, it was 2.8, and now is 1.5, 1.6 in these recent years. It is going to be 1.2 in later on. So Albania is changing a lot of the shape of the population. So the population also is decreased from 3.3 in 1990, and now is 2.8, and recent census was 2.4 million population, and it's predicted to be by the 2100 years. Here we see the shape of population of Albania, demographic changes, the pyramids. So we see the green light, the most of the population is getting middle age and old age. So it means that the health policy should be conducted, and to see how we can deal with the future with the people in this age, for the social support and financing this. The health system here, we see that expected, we say that in percentage, the health expenditure in Albania, it's around 2.7 to 3% of the GDP. But out of pocket, it's around 50% of this 3% is based in the out-of-pocket money. We shaped this because maybe to see the WHO Barcelona office for the health system financing here. We see here that Albania, is among country which is it's caused by out-of-pocket payment of health system. And here we share the household experience in impoverishment, out-of-pocket payment for health in Europe. So Albania is with Romania, Albania is higher than Romania compared to this. So for the lower and financial hardship, also Albania has this very hardship and financing in this. Yes. So we have also the poorest quintile here, Albania, and the average also is among the countries which are facing difficulty in the, let's say. Also this association here, here, we see the Albania out-of-pocket payment is share current spending in health. It's about the same, it's around 60 or less than 60% of them. And payment of social health insurance contribution, Albania has lower than Romanian here. I think the social contribution in Albania is half of the 1.7, I think, to be, can do this. And if we look here for the poorest household with catastrophic health spending, the diagnostic taste and inpatient care, outpatient care, the dental care here, and also also it can say is a private and not a public health system. Expect the schools, have seen that dental care should be covered by the government, and others. I mean, we have some medicines, also medical products, which was going to be paid, some of them by out of pocket of money to the patients. So if we see here that how well is the country of territory providing effective essential health services, I think here it's increased from 68.4 to 69.6. The average change per year is 0.2. It is universal health coverage index. And but what are the causes, I think, of this? We see the ischemic heart disease is the first places, as it's increased, 33.8, and lung cancer, Alzheimer, and the others. We have some data here, but I think that Professor Gens will deal here in his presentation chronic disease and also cancer disease. So we see that during the other, we have the infant mortality rate, also the mortality rate of 0 to 5 is decreased. Now it's 4.7 to 5.6 for 0.5. Also, I will skip this maybe to go that on complications and to see which are the main issue of the Albania, which is weak. The Albanian health system exhibit significant gaps characterized by underfunding and inefficient resource allocation. In 2023, public health expenditure was 2.8 of GDP, constituting only 9% of total government expenditure by European Commission 2024. The public health spending on health in Albania is rather low for meeting the population needs adequately, especially in the aftermath of COVID-19. In particular, resources allocated in primary health care are rather scarce. So rather, I think that more than 75% of the public health expenditure goes to the tertiary health, hospital care and other health care. In 2018, unmet health care needs were estimated 2.2%, 22% of WHO 22. In the human resource, I can say that currently Albanian systems suffer from the severe shortage of health professionals. So we have the ratio with 1.9 per 1,000 for doctors and 5.8 for 1,000 for midwife nurses. In 2023, survey revealed a very high potential migration rate of Albanian doctors. And also, we have this system, migration that we can call now the pragmatic migration. Now, we don't have only doctors who migrate outside, the nurses, but also the middle class is migrating to Western, especially to Italy and Germany. The other thing is that in Albania, we have the maldistribution, where most of the doctors and nursing are concentrated in Tirana. So most of the remote area and some cities which are far from Albania are facing with lack of nursing and doctors. So now the people, sometimes the government are calling the doctors who already are retired to go to work in a remote area or far from there. The other thing is that we have also some the number of the students of the Faculty of Medicine is submitting for years. It's increasing. I mean, so the government now has put in new rules how to bring and to have some incentive in order the students, after they finish the faculty, to stay in Albania. This policy was introduced last year, so each student who finished the faculty must stay in Albania 3 years after they finish the Faculty of Medicine. And the same thing was going to be introduced for other health professionals. The other side is that I think the the Ministry of Health and has to introduce also and to have some professional, we have opened different courses in order to have the best management of healthcare and the health financing system in Albania, only regarding to the incentives of the financial, but also the health professionals. So we hope that these changes will bring some improvement in health indicator of Albania regarding to to keep and also and that professional also to improve the quality of the health system and the healthcare in Albania. And the other thing is the raising cost in healthcare and medical services, population aging, and limited availability of modern technology and medical devices, which is a fragmentation of the health service. Continuous increase in citizen well-being and their expectation for high-quality health and medical services. This is because we have public health. We have healthcare, public healthcare system, but beside this, we have also the private healthcare system. But if we pay the health, our health insurance, our health insurance, doesn't, cover you all the services what you need, for example, in the public hospitals. So the people, after they go to private hospitals, so they have to pay from their pocket for different services. Besides this, also you have also the problem is that the medical, drugs. And if you go to the pharmacy and you ask for the drugs, the pharmacy recommend you this drug is better than this, but this drug is not covered by the health insurance funds, and you have to pay the rest of money. So this cost of, it is very high for Albanian, population. It's count to be 50% of their, of the expenditure in the health of this. Thank you.
Thank you very much, Professor. And the last but not the least, thank you, Cenk.
Thank you very much. Yeah, indeed, the last and least, I know for 3 reasons. We had these gorgeous presentations starting from David.
And we enjoyed to see you there.
And
so
secondly,
that's good.
Professor Roche already set the scene about Albania. And thirdly, much more importantly, I see that in these highly developed societies, the UK, Italy, and Romania, of course, you are done with cardiovascular diseases, diabetes, and stuff, chronic respiratory diseases, which is not the case in Albania, actually. Oh, the presentation is here. Thank you. So my presentation, picking up on what Professor Roche already started, I change a bit the discussion. So indeed, cancer, all types of cancer, constitute the main threat, mortality and morbidity in this part of the world where we are holding this gorgeous Congress. By the way, thank you very much. I'm delighted and honored to be here, and thanks to the Romanian Society of Preventive Medicine in general and in particular, Professor Roxana. Please keep it up. It's absolutely unique kind of event in Europe. And indeed, the quality of the presentations we have attended so far is absolutely remarkable. However, again, please let me go a bit back in a transitional society, rapidly changing, as Professor Roche set the scene So Albania has experienced in the past 3 decades what I would dare say England, Britain in general, and France, for example, have experienced in 100 to 150 years, 1 century and a half, with regard to the demographic transition. So just imagine a population which at the early 90s had not more than 3% of population age 65 plus. Nowadays we talk about at least 20%, 65 plus. And of course, as Roshi presented, it is explained by the sharp, embarrassingly very low fertility rate, coupled with increase in life expectancy, but also mechanical forces, that is massive emigration, which continues unabated, unfortunately. So there is massive emigration of young adults, and then mechanically this share of 65 plus is increasing rapidly, which leads us to this burden of mortality and morbidity as it was introduced in the earlier presentation. Most of these estimates are exclusively pertinent to global burden of disease study reported by the Institute for Health Metrics and Evaluation for a very simple reason, to make it comparable. So in terms of standardization with the regional countries and far beyond Southeastern Europe. So that's why we deliberately are not referring to our official statistics from the National Institute of Statistics, but just extracting data from the GBD estimates. Ischemic heart disease on top. So in this evolutionary stage, let's say Albania, demographic transition, which is reflected unavoidably in epidemiological transition. However, the dinosaur constituting cardiovascular diseases, top cause of mortality and morbidity, ischemic heart disease, and then followed by stroke. Lung cancer is the third one, Alzheimer, and chronic obstructive pulmonary disease, the next one. Well, politicians, sometimes they get upset, but when we present these yellow, green, whatever, you know that men are daltonic, let's say these yellow, green, standardized, age standardized estimates. So the positive news is that in Albania also there is a steady decrease in the age standardized both mortality and disease burden as expressed in terms of disability adjusted life years. So that's on a positive note. The proportional mortality of all NCDs together before COVID-19 pandemic was roughly 93, 94. It dropped, of course, due to COVID-19, as Roshi presented briefly. Albania was one of the countries which was severely hit in terms of mortality, middle-aged mortality, especially in men, COVID-19, but it's going back to, we have already reached 90% again. We are back to 90% of proportional mortality attributable to NCDs. It will go up to 92, 93 in the next couple of years. The same is reflected in the disease burden. In particular, cardiovascular diseases, they constitute roughly 55% of proportional mortality. To put it into a context, cancer mortality, all neoplasms together, according to GBD estimates, constitutes not more than 17, 18, maximum 19% of overall mortality. And within cardiovascular diseases, which on a positive note, again, there is a steady decrease in terms of age standardized estimates. Ischemic heart disease has the lead. However, there is a drop of about 25% in age standardized rates. Even a sharper decrease, luckily, with regard to stroke. However, and this is picking up again on what was introduced, in terms of mortality patterns, Albania has is somehow resembling, let's say, these developed societies. However, in terms of risk profile, risk factors, it's not there yet. So it's somehow in the lines of developing transitional societies, as long as high blood pressure is the top risk factor, which is not the case almost in no developed industrialized societies. High blood pressure is the highest, explains the highest burden of disease and mortality, and we all know from WHO it is one of the very best buys, and therefore there is a strong case in Albania. I know that, for example, our current Minister of Health, she's an oncologist, and she has one of her ambitions, positive ambitions, to fight cancer, and our government is investing a lot in cancer prevention and control. However, as public health professionals, we always say that first things first. So probably there is a strong case in Albania to fight cardiovascular diseases and metabolic syndrome by handling these very best buys in terms of control and prevention of hypertension. Air pollution is still there, it's improving, but it's still there, and we all know that it has a huge impact on cardiovascular disease. As a matter of fact, 1/4 of ischemic heart disease and stroke is attributable to air pollution in Albania. And because cardiovascular diseases pose a very serious case which should be handled in Albania. Albania has embarked upon this global initiative, May Measurement Month, since its opening in 2018, excluding 2020, COVID reasons. Albania is every year in this May Measurement Month initiative, where, of course, these are opportunistic samples. Nevertheless, there is a very ambitious and solid campaign trying to provide also counseling and advice to individuals regardless of their hypertensive status, yes or not. And some salient findings, prevalence in parentheses, as long as these are huge in terms of sample size, but yet not probabilistic samples, and therefore, in a sense, they are opportunistic/selective samples, so findings should be considered and interpreted with extreme caution when it comes to prevalence estimates. However, there is a solid somewhere range of prevalence values around 40%, which is not trivial at all. It is quite high. And the famous rule of halves in cardiovascular disease, especially, specifically hypertension, does apply based on the Albanian data, in the sense that among those who are evidenced with hypertension, almost half of them are not aware of their condition, and among those who are treated for this condition, only half of them have, unfortunately, controlled blood pressure, and therefore half do not. And there is a very long story about why half does not, treatment efficacy, compliance, and many other reasons. It behaves as it should, in the sense that pre-existing conditions are strongly positively correlated with hypertension. In terms of inequities, there is a very strong gradient in terms of education. Those with no formal schooling, 0 years of education, they do have the highest rates of hypertension, also the highest mean levels of both systolic and diastolic blood pressure. Interestingly, abstinence, alcohol abstinence, is a protective factor, which goes in line with Chris Murray's theory, actually. And physical activity, it behaves as it should, so individuals are reporting engagement in physical activity. They display the most favorable rates of both prevalence in terms of hypertension and also the lowest mean levels of both systolic and diastolic blood pressure. We do have a national program with regard to prevention and control of all NCDs, and cardiovascular disease are part of this, and also cancer. For cancer, by the way, we do have a separate cancer control program nowadays. This is quite ambitious, the national strategic plan with regard to control and prevention of NCDs. The Scientific Foundation, probably there is no room for refining these arguments, starting with primordial, primary, and secondary types of prevention. Priorities are set both at a population level and individual level, and for each there are certain pillars. For example, at population level, prevention through fiscal and marketing policies, promotion of physical exercise, and then when it comes to individual kind of level, cardiometabolic risk assessment and management, in line with early detection and treatment of NCDs, and cancer is within this framework as well. Vaccination, thirdly, it was mentioned briefly here. So all these priorities are embedded into our national strategy program. And supported interventions are equally important: promotion of oral health, mental health, and specific settings. And it will be one of my cases when I present a remarkable example in Albania with regard to introduction and nationwide school-based health promotion program. The implementation of this national strategy with regard to control and prevention of NCDs is based upon 4 domains: governance and coordination, prevention, health system strengthening, and the national supervision of NCDs. So let me, time-wise, highlight 2, in our view, remarkable examples with regard to how Albania is tackling the burden of NCDs. So combating cardiovascular diseases, diabetes, cancer, in general, NCDs. So the first one would be a unique exercise. Albania embarked upon a nationwide medical checkup program in 2014. This is the last year of this program. And the second one, as I mentioned earlier, it is a nationwide school-based health promotion program. With regard to the first one, checkup program, it was introduced in 2014, initially tackling only the population aged 40 to 65, both sexes. And then it was expanded 35 to 70 years. It is a bit of surprise in Western societies because always at the beginning of this nationwide program, they were puzzled. So why do we need such a program? It was the case of Albania because that age was somehow excluded from this control and prevention program, both primary and secondary / screening programs. And therefore it was indeed something which we as public health professionals were looking forward to implementing this kind of program. So this kind of a checkup foresees a very detailed and specific kind of assessment of major risk factors for NCDs, screening for selected types of cancer, cardiovascular diseases, diabetes, chronic respiratory diseases, and on top of that also risk factors, starting with smoking, nutritional habits, alcohol consumption, physical activity, sleep quality, stress. There is a short version, validated Albanian cross-cultural adapted version of depression scale, and therefore on top of assessment of selected risk factors and NCDs, citizens are also advised and counseled based on their results. So the unique feature of this checkup program vis-a-vis assessment is also counseling and advice. Okay, these are selected findings. Time-wise, I would skip it. Very interesting. So in terms of proportions, only for the prevalence of hypertension, more than half was detected. Individuals were made aware of their condition through this exercise, which is absolutely pointing to the need of such a program in a transitional society such as Albania, where levels of health literacy, we have publications, strong, solid, over time publications on that are relatively modest. And that's euphemism, are pretty low. Obesity is very high. But let's go to the last part, which is very exciting to us because this is a real example of how a school-based health promotion program at a national scale, of course, Albania is very small. We were doing this exercise with Roshi yesterday. There is a very beautiful pattern when we compare Romania and Albania, both in terms of surface and population. Albania is 10 times smaller than Romania. So just to put it into a context, we are talking about a population roughly 2 million, and therefore the efficacy, effectiveness, and then cost effectiveness of such programs are easier to be assessed, measured, and comprehend. So this program, funded by the Swiss government, it is a program which started in 2020 and will end in 2027 in the framework of a Swiss agency development cooperation program in Albania, is in line with our national health strategy and health promotion strategy. We have an action plan on both health promotion and mental health. The interventional approach is very interesting because at a national scale, and we are talking about 9-year schools, so kids, children from 6 to 15, roughly 16 years of age. All schools in Albania, 9-year schools, are approached online through online interventions, and on-site more than 10%, roughly 10% of schools, in-depth interventions, on-site interventions. The online interventions foresee a wide range of interventions, starting with the e-learning platforms where teachers, health promotion specialists, and also parents are offered, of course, free of charge. Modules, training modules, they get certificates and credits accordingly at their pace, so self-managed courses. Digital tools for children and their parents, but especially for children. One specifically designed no sugar, one in general for healthy nutrition, one with regard to promotion of physical activity. Another one was initially designed to control and prevent COVID-19 and later expanded into hygiene and environmental protection. The online applications are updated, optimized on a regular basis, are used, appreciated by children and parents and teachers. You know, in these optional classes, there is plenty of room to experiment and to play with these digital tools, and teachers and also kids find it quite useful. And in the last couple of years, we started these competitions both at school level, at municipality level, and the national level, digital health competitions, which turn out to be quite a nice experience and greatly appreciated by both teachers and children. And as a matter of fact, they turn out to be highly effective, so digital applications, they do make a change, so they are indeed useful tools in terms of promotion of healthy behaviors, something which we published in Health Promotion International. Another absolutely unique feature of this program is the promotion of oral health, and through the Swiss support, but also then picked up by the Albanian government. Now we have mobile dental clinics, units, which go to remote areas. Professor Roshi elaborated about the maldistribution of services, and part of that is trying to be handled with regard to provision of a mobile dental care to remote areas of Albania. There is also a manual for the so-called school health coordinators. One of the unique features of this program has been the introduction, the formal introduction of the so-called school health coordinators. It is usually a teacher of biology, gym classes, or civic education, or otherwise any type of teacher who has some relevance with health and everything, all disciplines, they somehow do have health relations, who are assigned in this position. They are trained on a regular basis, and then they are in charge of coordinating all health promotion activities. Grants from municipalities, so local government is empowered not only in terms of training, but also direct grants provision to the municipality, grants with regard to fostering a safe and healthy environments, and also grants for civil society organizations, individuals, the so-called agents of change at the community level, which turns out to be quite a successful experience. Training is a very wide and unique feature of this program. For those of you who have experience with Swiss projects, they are absolutely capacity building, essentially. They are capacity building projects rather than provision of a lot of money for infrastructure and stuff like that. So training of teachers, health promotion specialists at a local level, municipality experts and professionals, and local civil society organizations at a grassroots level, so as they are in the driving seat when it comes to promotion of health. Limited infrastructural support. We introduced in Albania the concept of health club. Of course, we did not reinvent the wheel. We somehow copied this successful model from Western societies. So in those on-site intervention schools, we experimented the introduction of health clubs, which turned out to be quite a successful experience. And for selected in-depth intervention schools, provision of equipment and devices, because they need a basic set of equipment to promote health. So if we look at the interventions through the lens of outcomes, three main outcomes of this project. The first one, strengthening capacity, skills, and knowledge of both children and parents. The second one, capacity building with regard to teachers, health personnel, and municipality personnel. And thirdly, at a national and local level, working with the government, so support of both local and central government. Different interventions for each outcome. For the first one, increase of knowledge and competencies of children with regard to healthy behaviors, improvement of teaching curricula, health promotion campaigns, the so-called health caravan, very, very nice community initiatives, strengthening capacities of caregivers, and also school capacities, as I introduced earlier, establishment of health clubs. Nutritional patterns, nutritional behaviors of parents and other caregivers turns out to be highly positively impacted by this project, and something which we published in the European Journal of Public Health. And similarly, strengthening capacities of teacher and school personnel turned out to be highly effective, and similarly in the same lines, support of government. And we coined the term Albanian health promotion model. So essentially this model, which in the center of that model are children and their families, it has this triangle, so strong coordination between local healthcare units, local government, and schools through their local educational offices. And of course then at a larger meso-level, community, civil society organizations, and the community agents of change at a macro level than the central government and other external factors. Something which we also published. And of course, as you know, all these Swiss projects are implemented in close line with these transversal themes, starting with good governance, social cohesion, and gender equity. That's pretty much, in a nutshell, these two kind of remarkable examples from Albania. Thank you very much for your attention.
Thank you, Professor Burazeri. So many wonderful ideas. I picked them up. Thank you. And if I may, I want to ask my colleague, my university colleague, Ioana Pop, WHO Romania, to conclude this wonderful session. Thank you, Ioana, that you are here.
Hello, everyone. Good morning. I'm not sure if it's morning yet.
Whoa, that was a great start of the Congress. Very interesting presentations. And before I conclude, I just want to say that I want to salute the rector of the University of Medicine and Pharmacy, Carol Davila, Professor Jinga, who is present. I just saw him now in the audience. You have the honor to listen to him later. I just want to say that we started with WHO, we started with Dr. Gatcher, and I just want to say that it is really a privilege and a genuine joy to be invited by Roxana to this second edition of the International Congress of Preventive Medicine. And the fact that you are here, clinicians, scientists, policymakers, advocates from Romania and Europe have come together. It's in itself a powerful statement for all the countries that are present. Everything that's going to happen in this Congress, every session, every speaker, every debate, lives within one of the pillars that the colleagues have discussed, so primary prevention, secondary prevention, and even tertiary prevention. From HPV vaccination to neonatal screening, from cancer, early detection to nutrition for children, from mental health education in schools to addiction, this prevention in its full, magnificent breadth. And it belongs to every medical specialty. That is the uniqueness of this Congress. I will not. I know we're late, so I will shorten my speech. I just want to say that it is really interesting to see, working in public health, how prevention has started to really cover a lot of the areas that we talk about in healthcare. In Romania, I'm talking about Romania. I work for WHO country office in Romania. And what I realized is that prevention is not a project. It is a partnership between all of these institutions, between the Ministry of Health, between the academics, between the universities, between the other medical and healthcare institutions in Romania, and of course with the healthcare workforce. The oncologist and the family doctor, the geneticist and the school counselor, the nutritionist and the cardiologist, the vaccination communicator and the mental health advocate, all of us in this room and in the following days, we speak the same language. And that is the spirit of this Congress. And it's really an honor to talk about prevention in this setting. In terms of Romania, Romania is not waiting. Romania has moved forward in prevention. We can see our objectives being met slowly but surely. And I was very intrigued by the Albanian presentation, and I could see a lot of similarities between our countries, which is again bringing us together. Although we're different countries, different cultural heritages, we are quite similar in terms of data. What I want to say is that Romania is moving. And with the partners like those in this room, and I think the future of preventive medicine in this country and in the countries that are present here today and in the following days is bright. I want to thank again Dr. Bohulțea for inviting me to close this panel, and I wish you very interesting talks. I know we're late, so it's probably lunch, coffee break now, so I will let you enjoy that. Thank you very much. Mulțumesc.
Thank you. Thank you, everybody. It was a wonderful panel with wonderful discussions. Thank you a lot for all lectures. And we go on. And if I may, I will speak in English because in Romanian because I want to announce. Okay, thank you very much. Cu permisiunea dumneavoastră, dați-mi voie să îl prezint pe domnul rector al Universității de Medicină și Farmacie Carol Davila București. Congresul de Medicină Preventivă se bucură de a se desfășura, de a avea loc sub egida Universității de Medicină și Farmacie Carol Davila, cu sprijinul direct al domnului rector, căruia îi mulțumim pe această cale. Mulțumim, domnule rector.
Da. Dragi tratare acum, m-a speriat. Dragi colegi, dragi prieteni, doamnelor și domnilor, trăim într-o perioadă în care medicina de înaltă performanță impresionează prin tehnologii, prin molecule noi și proceduri avansate. Dar, în același timp, nu avem voie să uităm o realitate esențială. Cea mai bună intervenție medicală este aceea care împiedică boala să apară sau să o descopere într-un stadiu în care poate fi tratată suficient. Iar aceasta este, de fapt, definiția modernă a responsabilității unui sistem de sănătate. În numele Universității de Medicină și Farmacie Carol Davila din București, salut prezența colegilor de la OMS România și a invitaților internaționali care aduc astăzi la București expertiză, modele de bune practici și un mesaj unitar. Prevenția trebuie să fie un pilon de politică publică, nu un capitol secundar. Ne bucurăm să avem astăzi în program Europe's Code Against Cancer, 5th Revision, un proiect care sintetizează în mod riguros și sensibil, necesar, accesibil, ceea ce știința ne spune despre cum putem reduce riscul de cancer la nivel populațional. Este mai mult decât un document. Este un instrument care ne poate ghida în politici publice, în planuri naționale, în programe de educație și în cele din urmă în comportamente. Prevenția nu este doar un ideal, este o investiție cu randament măsurabil. Reduce incidența, scade costurile tratamentelor complexe, reduce dizabilitatea și crește anii de viață trăiți cu calitate. Într-o țară unde resursele sunt mereu limitate, după cum bine știți, prevenția este una din cele mai inteligente forme de eficiență. Un punct central al zilei de astăzi este prevenția cancerului de col uterin și a cancerelor HPV asociate. Și vreau să vă spun foarte clar, pentru prima dată în istoria medicinei avem o categorie de cancere care poate fi în mare parte prevenită prin vaccinare și prin screening organizat. Totuși, între posibilitatea științifică și realitatea clinică, știți foarte bine că există foarte multe obstacole. În România încă vedem cazuri avansate, încă vedem suferință evitabilă, încă vedem intervenții mutilante, încă vedem familii devastate. De aceea, tema Accelerating HPV-Related Cancer, Elimination South East Europe, este crucială. Nu este doar un obiectiv european, este o urgență de sănătate publică și o datorie față de femeile din România. Salut prezența experților ESGO și a colegilor care abordează subiecte sensibile și actuale, precum utilitatea vaccinului HPV după diagnosticul unor cancere ginecologice. Avem nevoie de astfel de discuții bazate pe dovezi, nu pe opinii, pentru a traduce știința în ghiduri, iar ghidurile în practică. Masa rotundă despre strategiile de implementare a Planului Național de Screening, Update 2026, este, în opinia mea, miezul programatic, pentru că România are nevoie de programare, are nevoie de trasee clare, de indicatori, de calitate, de interoperabilitate a datelor și, foarte important, de comunicare publică. Screening-ul nu înseamnă doar să faci teste. Screening-ul înseamnă să construiești un sistem care invită populația țintă, care asigură accesul rapid, care are calitate standardizată, care urmărește cazurile pozitive și care măsoară mai ales impactul. Fără aceste componente, screeningul rămâne o inițiativă fragmentată care nu-și atinge obiectivul. Sunt de asemenea încântat să văd în program tema self-care și a reorientării sistemului de sănătate pentru secolul 21. Realitatea este că majoritatea determinanților în sănătate nu sunt în sala de operație, ci sunt în comportamente, în educație, în mediu, acces la servicii preventive, alfabetizare în sănătate. Un al doilea punct la care vreau să mă refer este rigoarea care trebuie să devină prevenție măsurabilă, nu slogan. Dacă prevenția devine discurs fără instrumente, ea rămâne promisiune. De aceea rigoarea este cheia. Rigoare înseamnă indicatori, acoperiri, calitate, trasee, audit și responsabilități clare. Și așa cum aminteam puțin mai devreme, mă bucur că o piesă centrală a acestei ediții este masa rotundă dedicată implementării Planului Național de Screening, pentru că investigarea persoanelor asimptomatice este poate cel mai bun exemplu de prevenție care cere rigoare, fără registre, fără invitații funcționale, fără trasee de confirmare și fără acces rapid la diagnostic și tratament, screeningul devine excepție, nu o rutină. Iar o țară nu se schimbă prin excepții. Și în fine, ajungând la cel de-al treilea punct, solidaritatea. Putem afirma cu tărie că prevenția este un sport de echipă. Ea nu poate fi monopolul unei singure specialități și nici a unei singure instituții. Ea cere colaborare între medicina de familie, epidemiologie, sănătate publică, specialități clinice, laboratoare, universități, administrație și societate civilă. În această sală există un adevăr pe care îl știm cu toții, dar pe care trebuie să-l repetăm până devine reflex. Fără cooperare, prevenția se fracturează. Rolul universității, alături de OMS și de partenerii europeni, este să formeze profesioniști care să știe să lucreze aceste determinate importante, medii de familie, specialiști, epidemiologi, psihologi, asistenți, manageri de programe. Universitatea noastră își asumă rolul de a forma medici care cunosc dovezile, care înțeleg prevenția, au competențe de o comunicare, mai ales interdisciplinară. În același timp, suntem pregătiți să sprijinim proiectele de sănătate publică prin cercetare, prin evaluare, prin standarde de calitate și prin conectare la rețelele europene. Doamnelor și domnilor, astăzi nu vorbim despre un capitol secundar al medicinei, vorbim despre viitorul sănătății. Dacă vrem să avem spitale mai puțin aglomerate, dacă vrem să avem tratamente mai eficiente și mai accesibile, dacă vrem să reducem mortalitatea evitabilă, dacă vrem să mutăm centrul de greutate al sistemului către prevenție, este foarte important și mai ales către vaccinare, către screening și educație. Medicina preventivă este o formă de responsabilitate față de viitor. Nu înseamnă întotdeauna să aibă aplauze, nu întotdeauna se vede imediat, dar este poate cea mai nobilă parte a medicinei, aceea în care succesul înseamnă că nu s-a întâmplat, înseamnă boala evitată, înseamnă complicația prevenită, înseamnă suferința redusă și bucuria longevității. Vă mulțumesc tuturor pentru prezență, le mulțumesc invitațiilor internaționali pentru generozitatea de a împărtăși expertiza lor, vă doresc o zi de lucru cu idei aplicabile și cu concluzii care se transformă în acțiuni. Vă mulțumesc și vă urez mult succes!
Vă mulțumim foarte mult, domnule rector. Nimeni nu ar fi putut să tragă niște concluzii mai pertinente, să spună lucrurile mai bine decât ați făcut-o dumneavoastră. Vă mulțumim foarte mult că ne-ați onorat cu egida Universității de Medicină și Farmacie și cu prezența dumneavoastră. Și cu permisiunea noastră mergem mai departe. Dați-mi voie să o prezint din partea Casei Naționale de Asigurări de Sănătate pe doamna dr. Elisabeta Iuliana Brumă, director reglementări și norme de contractări, Casa Națională de Asigurări. Așa cum am promis, acest congres înseamnă prezența factorilor de decizie, prezența mediului universitar și prezența noastră a celor care trebuie să aplicăm aceste norme de medicină preventivă. Vă mulțumesc că sunteți aici.
Mulțumesc pentru invitație. Din partea domnului președinte al Casei Naționale de Asigurări de Sănătate, vă rog să-mi permiteți să vă adresez câteva cuvinte. On behalf of the National Health Insurance House, we would like to express our sincere appreciation for the invitation to participate in this international event. We warmly congratulate the organizers for creating such a valuable platform for dialogue, exchange of expertise, and collaboration in the field of healthcare. In the context of increasing pressures on healthcare systems, particularly those facing limited financial resources, we firmly believe that prioritizing prevention represents the wisest and most sustainable path forward. Investing in preventive services not only improves population health outcomes, but also ensure more efficient use of available resources by reducing the burden of advanced diseases and costly treatments. Our institution has placed prevention at the core of its strategic direction, promoting early detection, risk assessment, and proactive care through strengthened primary healthcare services. We are confident that a system oriented towards prevention can deliver better results for patients while maintaining long-term financial sustainability. Next, I would like to present some of the recent achievements in the field of prevention with the social health insurance system. Starting with the framework contract that came into force on 1st of July 2023, the focus in the social health insurance system shifts from curative to preventive care through the restructuring of services packages and changing in reimbursement levels, particularly in family medicine. Preventive services are paid 2 or even 30 times better than curative services. Diagnostic and therapeutic services have been introduced that can be provided not only at the family doctor office, but even in community, at the place of request, and where the patient lives. Preventive services in order to are better paid in order to facilitate the rapid resolution of cases and avoid unnecessary hospitalization. These services are provided not only to insured individuals but also to uninsured with similar packages. The minimal package which is provided to uninsured is similar to the basic package which is provided to insured person. Moreover, any person registered with a family doctor becomes eligible for preventive care even if a person is recorded as having a chronic disease. They can benefit from 2 consultations per year, preventive consultations. These consultations are adapted to the patient age. For example, for those over 60 years old, early detection is carried out for dementia, osteoporosis risk, or urinary incontinence, in addition to other early detection activities such as oncological and cardiovascular risk, screening for depression, problematic alcohol use, lifestyle factor, diet, etc. New preventive services are also introduced with other types of consultations for patients who do not show signs of diabetes or chronic kidney disease but are at risk of these conditions. Tests such as blood glucose, glycated hemoglobin, and serum creatinine with estimation of the glomerular filtration rate are prescribed. All investigations recommended following preventive consultation have been reimbursed beyond the contractual value of paraclinical investigation providers since 1st of July 2024. 1 year earlier, this was possible only for those preventive investigation prescribed for the patient over 40. At the level of the family doctor, monitoring of patient attendance for preventive examinations has been introduced for the early detection of cervical, breast, prostate, and colorectal cancer. All investigation for patients with suspected cancer have been reimbursed beyond the contractual value since 1st of July 2024. All service packages have been revised so that the time from suspicion to a complete diagnosis, which can permit to establish treatment by a multidisciplinary team, is as close as possible to 28 days. This is our aim. This is our goal. In outpatient specialty care, new medical services for diagnostic purposes have been introduced, allowing HPV testing and PAP testing when HPV result is possible. We highly value opportunities such as this conference, which foster international cooperation and the sharing of best practices, which I saw earlier. The reimbursement of immunological medicine used to produce active immunity, as each for HPV, from which certain population group benefits in outpatient treatment, is now 100% reimbursed for people lower than 26 years old. Despite all the legislative progress made in recent years, prevention remains secondary in a collective mindset. There is a lack of prevention culture in Romania, which early education in schools remain a decisive factor in changing this mentality. At present, the dilemma persists between making prevention mandatory and living as a personal choice. The public healthcare system, despite permissive legislation regarding prevention, is slowly reorienting itself. It remains the responsibility of each of us to contribute from wherever we are, and including through personal example, to encourage the choice of prevention so that gradually the overall mindset will eventually change. We look forward to continued collaboration in advancing prevention as a central pillar of modern healthcare system. Thank you once again for your invitation, and we wish you a successful and impactful event.
Mulțumim foarte mult. Dați-mi voie să merg mai departe, prezentându-vă pe doamna profesor, dr. Diana Loreta Păun. A reprezentat administrația prezidențială, a susținut Societatea Română de Medicină Preventivă încă de la fondarea ei, este profesor, doctor endocrinolog și în curând ne va ajuta mai mult decât atât, se va implica mai mult decât atât, fiind viitorul vicepreședinte al Societății de Medicină Preventivă. Vă mulțumim foarte mult, doamna profesor.
Mulțumesc eu, doamna profesor. Bună ziua tuturor. Hello, good afternoon. It is a real honor and pleasure for me to be here today, and I want to congratulate Professor Roxana Bohâlțea for her dedication and professionalism. Now I will switch into Romanian and permiteți-mi să vă prezint câteva idei din experiența debutului Societății de Medicină Preventivă și respectiv al acestui congres. În primul rând, este o deosebită onoare să vă urez bine ați venit la deschiderea oficială a Congresului Internațional de Medicină Preventivă. Reuniunea noastră de astăzi reflectă nu doar importanța acestui domeniu, ci și responsabilitatea comună pe care o avem față de viitorul sănătății la nivel global. Trăim într-o perioadă în care medicina nu mai poate fi definită doar prin capacitatea de a trata boala, ci mai ales prin abilitatea noastră de a o preveni. Medicina preventivă devine astfel fundamentul unui sistem de sănătate sustenabil, eficient și orientat către individ. În acest congres, temele congresului nostru nu sunt doar actuale, ci sunt esențiale pentru direcția în care ne îndreptăm ca profesioniști și ca societate. Medicina preventivă globală ne invită să privim dincolo de granițe, să înțelegem că sănătatea este un bun universal, influențat de mulți factori, sociali, economici, de mediu. Într-o lume interconectată, provocările sunt comune, de la bolile cronice la riscurile emergente, iar răspunsurile trebuie să fie coordonate, trebuie să fie bazate pe colaborare internațională și pe schimb de bune practici. Viziunile și strategiile în medicina preventivă trebuie să fie clare, dar mai ales adaptabile. Este nevoie de politici bazate pe dovezi, de educație continuă la nivelul populației și de implicare activă a comunităților. Prevenția nu este doar responsabilitatea medicilor, ci un efort colectiv care implică orice individ. Unul dintre pilonii centrali ai acestui congres este prevenția și detecția precoce a cancerului, despre care s-a vorbit. Domnul rector a subliniat în mod deosebit această temă. Știm cu toții că depistarea precoce salvează vieți. Investiția în programele de screening, în tehnologii inovatoare, dar mai ales în educația populației, la care, din păcate, populația României are o serie de probleme, reprezintă pași concreți spre reducerea impactului acestei boli. În același timp, dezvoltarea centrelor multidisciplinare ne permite să abordăm pacientul într-un mod integrat, reunind expertiza diverselor specialități pentru un diagnostic rapid, pentru un tratament personalizat și mai ales pentru a asigura un traseu corect al pacientului. Medicina stilului de viață ocupă de asemenea un rol central în discuțiile noastre: alimentație, activitate fizică, somnul, gestionarea stresului din ce în ce mai prezent în viețile noastre. Toate acestea nu sunt doar recomandări generale, ci intervenții terapeutice cu impact deja demonstrat. Într-o epocă dominată de un ritm alert și de multe obiceiuri nesănătoase, promovarea unui stil de viață echilibrat devine o prioritate. Tema longevității și a anti-aging-ului deschide noi perspective asupra modului în care înțelegem îmbătrânirea. Într-o societate în care speranța de viață crește, iar bolile cronice devin din ce în ce mai prevalente. Nu mai vorbim numai despre a trăi mai mult, ci a trăi mai mult și mai bine. Calitatea vieții, autonomia, sănătatea funcțională devin obiective principale ale medicinei moderne. Genetica în medicina preventivă aduce o dimensiune revoluționară în modul în care abordăm riscul și prevenția. Posibilitatea de a identifica predispozițiile individuale încă de la naștere ne permite să personalizăm intervențiile și să acționăm înainte ca boala să se manifeste. Este cel mai important pas către medicina viitorului, medicina de precizie. Nu în ultimul rând, medicina integrativă ne amintește că pacientul este mai mult decât suma simptomelor sale. Abordarea holistică, care îmbină medicina convențională cu terapii complementare validate științific, contribuie la o îngrijire mai completă și, de ce nu, mai umană. Dragi colegi, acest congres nu este doar o platformă de prezentare a celor mai recente descoperiri, ci un spațiu de dialog, de inspirație și de colaborare. Este locul în care ideile se întâlnesc, se dezvoltă și sperăm se transformă în acțiuni concrete. Vă încurajez să participați activ, să împărtășiți experiențe, să puneți întrebări și să construiți punți între discipline. Progresul în medicina preventivă depinde, în primul rând, de capacitatea noastră de a lucra împreună, de a învăța unii de la alții și de a rămâne deschiși la inovație. În încheiere, aș dori să subliniez că prevenția nu este doar o strategie medicală, este o filozofie despre responsabilitate, despre anticipare și despre grija față de viitor. Prin eforturile noastre comune putem contribui la o lume în care sănătatea nu este doar un ideal, ci este o realitate accesibilă tuturor. Vă mulțumesc pentru prezență și vă doresc un congres plin de idei valoroase, de colaborări fructuoase și de multă inspirație. Mulțumesc!
Propunerea mea este să mergem cu toții în spate, să luăm câte un sandwich, pentru că, din păcate, este zgomot și nu apreciem la întreaga valoare prezența speakerilor de care ne bucurăm. Vă poftim la masă, deci, cu drag și revenim într-un sfert de oră, dacă nu vă supărați, pentru că mâncare foarte mult oricum nu este, deci mulțumim mult! În limita posibilităților, atât s-a putut. Mulțumim!
Like this, I should go. Okay.